Hello and good morning. A very warm welcome to all. We are having a hybrid seminar today. So we have people online as well as in person today. And thank you all for being here. So today, Sir H.N. Reliance Foundation Hospital, in association with the Bombay Seaward Medical Association and the Bombay Medical Union, would like to invite you for this webinar on the update in lung transplant. So respiratory medicine per se has grown in leaps and bounds. It used to be called only a specialty of TB, and that we have far progressed from. And the most exciting times of respiratory medicine are now. And one field which has definitely progressed in leaps and bounds has been in lung transplantation. So we have uh, unfortunately, we have our managing committee team from the C ward, and I would like to thank Dr. Kamlesh Shah, Dr. Anil Mehta, and Dr. Jawar Mukhtiar, who have always been very supportive of these programs. And thank you again for helping us in organizing this. Before we start off, I would like to just sorry, screen share. So a few days ago, on the 29th of August, we lost one of our stalwarts, our dear Dr. Mahashur, who aptly filled the roles of teacher, mentor, guide, and a true inspiration. He will always live on through the countless lives he's touched. Patients and students alike remember him fondly. His strong teaching and clinical base that he has instilled into each of his students has led them into academic careers all over the world. We will all agree about the great role he played in giving shape to his students and clinical learning. Truly, his loss is an end of an era, and there will never be anyone like him. As a mark of respect, may we have a minute of silence for him, please. Thank you. So to begin the proceedings of the day, I will just talk you through the four talks that we have. Uh, the first one, we have all stalwart speakers with us, very well known in the city and all over the country. The first lecture that we're going to have is when to refer to lung transplant clinic by Dr. Prashant Chajar. The next one will be pulmonary rehabilitation in interstitial lung disease by Dr. Prahlad Prabhudesai. Then we have surgical considerations in lung transplantation, selecting the candidate by Dr. Sandeep Atawar. And last but not the least, preoperative evaluations in lung transplantation by Dr. Unmil Shah. This will be followed by a panel discussion and vote of thanks. So as we get ready with our first talk, I would like to thank and invite Dr. Prashant Chhajar. All of our speakers need little introduction because they're all very well-known faculties. He's the director of Lung Care and Sleep Center at Santa Cruz, Mumbai. He is one of the most dynamic interventional pulmonologists around. He's affiliated with Fortis Hiranandani Hospital at Vashi, Lilavati and Nanavati hospitals. His brevet dosant was done at University of Basel in Switzerland. He's the ex-chairman of Interventional Pulmonology Group at the European Respiratory Society. He was also member of Governing Council of the Indian Chest Society and the ex-secretary of the Indian Association of Bronchology. He has numerous publications and abstracts to his name, and he's been on editorial boards of pretty much all our high-impact journals, which includes Lung India, Respiration, the Indian Journal of Chest Diseases and Allied Sciences, Journal of Bronchology and Interventional Pulmonology, and Chest, which is the official journal of the American College of Chest Physicians. So we welcome Dr. Chhajar. Over to you, please. Sorry, we'll be with you in a minute. But as we are loading our first talk, I would request everybody in the audience, online as well as in person, that if they can jot down some questions, because we have a good session of discussion afterwards. And the whole idea for this half-day program was so that we make awareness of who should be referred, when they should be referred, and that we can actually make a difference. So again, I would request everybody to through the course of the talks, If you have any questions, please jot them down because we'll be more than happy to share and discuss these out.
So, sorry about the technical delay. Unmil, thank you very much for this invitation. Thank you very much for the very kind introduction as well. So, I think the topic that has been given is about when to refer for lung transplantation, and I think that's a very important point from a pulmonologist perspective. Also, an important point. I mean, from a community pulmonologist perspective, like us, and I mean, and also for the physicians, for the critical care people, because whenever there is a situation, I think what is the most common situation when we get called in for a lung transplantation is when the patient is on the ventilator, 100% FiO2, now nothing can be done. And then, so that is the most common indication we get called in for, is this patient suitable for lung transplantation? And I think what we need to do now is, I think it's a very good initiative. We need to educate everybody on actually what are the indications for lung transplant, more than indications, when to refer, because what happens is, I'll tell you, if an inappropriate mention of a lung transplantation is made to an inappropriate patient, then the whole family panics. They try to go helter-skelter looking for an option of lung transplantation when it may not be feasible. A lot of feeling of guilt is there. So I think, Unmil, thank you very much for organizing this talk, and I'll do whatever best. For me, it's a deja vu, going 20 years back. So, yeah. So the referral, so I think when we talk about referral for lung transplantation, we are talking about referral in a patient with chronic respiratory disease. Of course, we will be communicating, we will be discussing acute situations when you talk about transplantation, but we talk about in a chronic respiratory disease where a patient has a chronic lung disease. When do we think about transplantation? When do we start thinking about lung transplantation as physicians? And when we should be, planting that small seed into the family and the patient. So it has to begin transplant becomes urgent, So what I was talking to you is what is urgent transplantations. I think we need to think about urgent transplantations, Yes, it is an indication, but it's a small indication. Patient should be, ideally patient should, ideally patients should be referred for transplantation before they meet the criteria for transplantation for listing. Okay, so if today the patient it qualifies for transplantation, that may be a little bit late, because there are many things which are important when we talk about listing the patient transplantation. Is a preoperative evaluation, and we'll discuss to you about it. And I think we need to find the right time frame when the patient should be meeting a transplant clinic and discussing about transplantation. Early referral allows people to, there are a lot of modifiable factors. A lot of optimization is required. All those factors can be taken care when you refer the patient at the right time. Vaccinations need to be done. We know that in immunosuppressed patients, the vaccination can take time. So, patients should be vaccinated at an appropriate time. Of course, I think most of us in pulmonary, in a respiratory practice, are already doing it. The time for full evaluation for transplant needs assessment of potentially modifiable risk factors. We've discussed that. Patient disease trajectory, that needs to be estimated and discussed. Sometimes a precipitous fall, in the patient's health leads to a referral under less ideal circumstances. So this is what it is. Patient has been stable for 1.5 years. Suddenly there's a drop, exacerbation. Now patient who was not on oxygen or 4 liters of oxygen, and then again you're going helter-skelter looking for this option of lung transplantation. But one thing I must tell you is, even in the chronic respiratory practice, I think we need to find out the right time when we tell the patient about it, in what way we tell, because the minute in the ILD patient, Prabhu Desai is here, one of the most experienced senior clinicians in the pulmonologists in the city. We have a lot of patients who are stable on chronic respiratory disease, on ILDs or COPDs, with antifibrotics, with NIVs, etc. So whenever you talk about transplantation, it can cause panic in the family, and we have seen that. So I think that has to be also communicated efficiently. And the way I follow it is, I don't say, chalo abhi jaake mil ke aano. We start that, this is some, in the first visit, we'll say, okay, one of the visits will say, okay, you need to think about transplantation. This is an option, but we'll discuss it next time. So they have time to think about it. So they know, yes, it's an option for this disease, but it's not really something that they need to panic about. Referral of patients on life-sustaining interventions such as mechanical ventilation, ECMO as a bridge to transplant may be considered in highly selected patients at centers with expertise. And I think these are one of the most common. I'm sure Urmil must be getting a phone call every second day for these urgent transplantations. So urgent transplantations do not have a good outcome. They have you need really a good center of expertise. All the ECMO, the ventilation, all those things really need to be managed very well before these patients are taken up. So the point I'm trying to put across here is, and I'll build this up as we go ahead, we're talking about chronic respiratory disease patients, and in these patients, we will talk about, what criteria, what are the risk factors, when do we talk about age? Now, age, ideally, age 55, 60 is the ideal age, the young patients. Whenever we are looking at IPF patients, ILD patients, the minute we see a younger patient, we get, where we are much more conscious, much more alert about these younger patients, because in these patients, first of course you need to optimize them as much as possible. You need to stabilize them as much as possible with our conservative treatment. But I mean, those are the patients where transplantation is something one needs to think about. Now, age more than 65 years can be considered as a relative contraindication. I'm not going to go into the details of and read out everything for you here, but the message that comes out is you can also consider age more than 65 years for transplantation. Okay, I mean, I spent many years in lung transplantation where 62, 65 was the cutoff, and we used to really think very hard before we would want to do more than more than 65. But now you see the number of more than 65 is increasing. The short-term survival of these patients is similar to that of a younger patient. Long-term survival we still need to look at. But the more important is, how do you select these individuals more than 65 years of age? These individuals should have less comorbidities. So if you have an individual who's more than 65 who has multiple comorbidities, and then you have an individual who's pretty well built, has got a good pulmonary rehab, Dr. Prabhu talked about it, well maintained, and no comorbidity, only a single organ, maybe in that patient, one will say, okay, I will consider this patient in my listing. So despite this selection bias and several short-term outcomes, lung transplantation over the age of 70 have decreased long-term survival. So I think 70 is a sure no. Less than 65, you need to strongly think about it. And more than 65, you need to evaluate and look at the comorbidities. Now, these are the absolute contraindications for lung transplantation. I think all of us really need to understand this very well. Because again, most important is we need to be fair with our patients. We need to be fair with the family. No panic. This is extremely important. This list is very big. The important thing I will tell you is septic shock. Patient is in sepsis on 100% oxygen, and then somebody will say, "Abhi isko khali transplant hi possible hai," and then it's a wasted. You're wasting the transplant team's time. You're wasting the patient's time. There's so much of. I think the transplant team needs. We are very limited people in the transplant clinic. They need to spend time more with people where the results are likely to be better. So septic shocks, no. Active extrapulmonary disseminated infection, sepsis, blood culture is positive. Okay, no, these are not the patients who are at that point considered to be fit for transplantation. Active TB infection. Last week, we have the patient who's actually been airlifted from one state to the other for active TB, and the patient there said, families were asking too many questions, "Aap iska transplant ko kaisa transplant karega?" So active TB infection patient has been airlifted last week. Limited functional status, non-ambulatory patient is in bed for more than several months, years. There's no pulmonary rehab, there's no muscle mass, there's no chance that these individuals, even if you put them new lungs, you need more than new lungs for a patient to have a successful transplantation. So whom should we talk? When we refer, I think as physicians, we need to think with whom we need to talk about lung transplantation also. So these are the list. So somebody who's bedridden, muscle wasting, osteoporotic, just, those are the patients where we say, okay, we may not think about it. So you have absolute transplantations, you have risk factors, with a high risk, and then you have only risk factors. So these are risk factors with high risk. Okay. Now, all this thing is available on the ISHLT website, or in the document, and the idea of putting these slides together is just to use these slides as a discussion and give our perspective when I think about referring a patient. And of course, I'm here to learn from you guys how I can think better. So candidates with these conditions may be considered in centers with expertise specific to the condition. That means these individuals are a relative contraindication, but there may be certain expertise some centers have. We'll go ahead. And in that case, in certain scenarios, you may consider high risk individuals for transplantation. You need to look at the modifiable conditions, and you need to think about optimizing them. So what are these high risk factors that we are talking about with the increased risk? This is the big list. Age more than 70 years, you have to be very selected. That this individual really needs biologically at around 55, 60 to think about that. But again, you need to be having a special center for that. Coronary artery disease, yes. If a patient has coronary artery disease, patient is well maintained, patient otherwise fits for transplantation, there are situations where you do a cabbage and transplant together, but you need special situation, you need expertise for that. Cerebrovascular disease, you really need to think about this. Chest wall and spinal deformities, this one really needs to understand this. point number 17. I've highlighted some of the important points which I have come across in clinical practice when patients have asked about transplantations, colleagues have asked about transplantation. Chest wall spinal deformity is very difficult. I mean, unless you have a very, it's not a very severe deformity. But I mean, just imagine somebody has a deformity, you're going to bring in lungs, and you're going to try to fit them in that. No, it doesn't work. Okay, it doesn't work in that case unless it's a special situation and the surgeon feels, the team feels that yes, there may be a chance. Point is, whenever we are dealing with such patient community, we need to tell patients, "Nahi, tumhare transplant hi nahi." No, we need to see if that is a feasible option, and that's how we should communicate to the patient. Then, of course, extracorporeal life support. These are so any individual who is needing extra support has more than a lung problem. That's the high risk individual, and that needs to be thought of. Now we talk about risk factors. What are the risk factors? These risk factors, suppose if one or two are there, they may be manageable. But if you have multiple of the risk factors that I'm going to show in this slide, if you have multiple risk factors here, then the outcome is not going to be good. Okay, why am I discussing all this with you? Because we are the first point of contact in the community with the patient. We need to assess these factors, and then we need to, our job is also to identify the more appropriate patients who can be referred forward. So all these issues are there, which are risk factors. Suppose if you have a couple of them, then you can say, okay, let's see, whether we can fit it in. Now, disease-specific considerations. Now, disease-specific considerations, the most common, I think, indications, of course, are COPD, interstitial lung disease, bronchiectasis, cystic fibrosis in the other, in the other countries. We have non-CF bronchiectasis, LAM. These are the common indications for transplantation. In the last years, post-COVID fibrosis has been an indication. So I'll stick the discussion mainly to COPD and to ILD. Now, when we talk about COPD, the question is, when do you refer these patients? Now, and I think this is where our senior colleagues who are here will be very, their opinion, that process of how a patient's trajectory is in the community, that we have to understand, because many chronic patients will do fine in the community on chronic care, and there will be some of them whom you will really need to pick and choose and refer for the transplantation at the appropriate moment. So the ISHLT has given various criteria. You have the board criteria, that is the that is the BMI airflow limitation, that is the FEV1, the dyspnea index, and the 6-minute walk distance. So you take this criteria, you make a score, and then you see that. So on one hand you have numbers, and on the other hand you have a patient who's there in front of you. So the board index, a lot of details have been given. The other thing is the diffusion capacity. The diffusion capacity, if the diffusion capacity is very low, then yes, you think that then that individual becomes somebody whom you would start to think about transplantation if the other factors such as age and other factors are also conducive. Now, board index, I don't want to go into the details of board index, but board index is something which is there. That means you look at what is the BMI of the patient. Some extremely low BMI of 15, 16, 17, a COPD patient who's lost absolute all muscle mass and all, that will give a negative point in the board index. Somebody who is the FEV1, if the FEV1 is extremely low, that gives a negative point in the board index. Dyspnea, if the patient has a lot of dyspnea, you look at the scale, if dyspnea, very minimal exertion, that gives a low score. And on the 6-minute walk test, E is exertion. If the individual's oxygen drops down to less than 90 or less than 88, that's what then that gives another negative score. So these factors are what we call as objective factors, but we must take into account the clinical factors, because we will have many patients who are actually desaturating or walking, but they do fine for many years, because now with neotherapies, you want to optimize them, you give home oxygen, you maintain other things, So I think it's a very, very rapidly evolving situation, particularly with neotherapies, better adherence of patients to medications, oxygen and NIV. Of course, an individual who's on oxygen NIV is clearly, has a higher risk of mortality in the next couple of years. And therefore, you need to think about transplantation in these individuals. Patients are hypercapnic. whose carbon dioxide levels are high. Those are the individuals where you need to say, okay, this individual is hypercapnic, this guy is young, this guy from the age criteria, from morbidity criteria might fit into transplantation. You need to start thinking about transplantation there. So then again, lung volume reduction, we don't have that in our country as from a surgical perspective. Bronchoscopic volume reduction, one of the technique has become available. The point is this lung volume reduction in emphysematous lungs. Well, the idea is to reduce the lung volume either with surgery or bronchoscopy techniques, reduce the lung volume, give a mechanical advantage to the individual for breathing. All these are bridges to transplantation. So the point that I come across is at any point you think your emphysema COPD patients could benefit, who's very hyperinflated, would benefit from a volume reduction procedure. Those are the individuals. At that point only you could start thinking whether these individuals should be, you should refer them to a parallel evaluation for a transplantation. Interstitial lung disease. I think that the game has changed a lot in the last 7 to 10 years, I would say, with the advent of antifibrotics, our better understanding of interstitial lung disease. I think this is a point. I think, even in the, as I said, the outcomes are better. I've put up a very important point here. None of the trials have shown that antifibrotics actually improve survival, in a strong controlled manner. But there's a lot of post hoc data, a lot of follow-up data which shows, and then there are a lot of mathematical models which have shown that there can be a survival advantage now if you give antifibrotics to patients with interstitial lung disease. What does this mean? Earlier, if you had somebody had IPF, you would say, okay, median survival 3 years now, and going down trajectory, already diagnosed for more than 2 years. Now you need to think about transplantation. The game may be slightly different, with the advent of antifibrotics. So one more point I'm trying to put, I would like to put across is, there are 3 points here. One is the communication from the community physician to the patient. The other point is the community physician and the transplant physician talking about that particular patient. That becomes extremely important. Just planting a seed for transplantation doesn't mean that next day you do transplantation, but I think this coordination, discussing how this patient is doing, maybe a 6-monthly follow-up with the transplant clinic, and then you're following that patient every 3 months, or maybe a yearly, depending on the, on the patient's trajectory. I think the communication between the community physician, I feel, is important when you do it with the transplant clinic as well, so that we can discuss the stability of the patient, the other parameters of the patient, because the community physician, chest physician like us, who's in daily touch with the patient, can have a better feel whether the patient is stable or is on the declining. Because if you look at the numbers are, the numbers that are important. The numbers say you should look whether the lung function is falling down. You should see whether the FEV1, FVC, the 6-minute walk test distance is falling down, or your oxygen desaturation is happening when you walk. Okay, so all these factors are important, but along with that, overall how the patient is doing in terms of exacerbations, in terms of symptom relief, in terms of day-to-day activities, in terms of mobility, these are also very important, are extremely important factors when we talk about referring or a patient of ILD for transplantation. Numbers are important, but the clinical scenario is also very important. If somebody's got supplemental oxygen at rest, that's the time when you think that, yes, you have to consider transplantation. But I mean, we have got so many patients who ILD have been stable and who are for 5 years on home oxygen, and then you look. So we need to identify these patients properly. Now, these are disease-specific considerations in interstitial lung disease. Again, the idea what I'm trying to tell you is you need to, again, these are International Society of Heart Lung Transplant guidelines. If you see that absolute decline in FVC more than 10%, decline in DLC of more than 10%, so radiographic progression, all these things, even if your patient is stable or not complaining to you, if these things is happening objectively, these can, put up a flag. You need to be more, you need to have a conversation with the patient. Maybe sometimes the patient is not able to communicate properly. Discuss with the family that whether these physiological, radiological declines which are happening, whether how they match with the patient's condition also. So you need to put everything together. And again, the idea of understanding this is, if your patient is being referred to a transplant clinic, then whether this individual needs appointment before the next scheduled appointment. Or if it is not referred, then you need to refer the patient. Pulmonary hypertension is something which is important, yes, but we see pulmonary hypertension very commonly in our country, and in many patients with chronic disease. We need to understand that better, that just the, an echo showing, a 2D echo showing a pulmonary hypertension might upfront may not be the reason for referral. I think that would need more evaluation. Now, as far as, this is a very important point, as I said, for interstitial lung disease. We know there are two antifibrotics which have come up in the last decade. One is pirfenidone. Everybody's using, India is one of the first countries to have, after Japan and some other countries, to have pirfenidone. So I think as a community pulmonologist, have a good experience about the of pirfenidone and its impact in the management of interstitial lung disease. Then we've got nintedanib. Now, pirfenidone and nintedanib have made a good impact on the management of fibrotic ILDs. But nintedanib, there is also concern that nintedanib, being an anti-VEGF, may be also affect wound healings, etc. So there was always a concern about bleeding, wound healing, etc. Whether people who are already on nintedanib, if you transplant those patients, will they have a wound dehiscence? Will they have some more complications than somebody else who's not on nintedanib? But if you, these were theoretical issues which have come up, but overall it seems from the data it doesn't seem to have any implication immediately on the post-operative outcomes as far as anastomotic healing, etc. is concerned, and no increased risk of bleeding so far. Now, when we talk about ILDs, you have an IPF and you have a non-IPF. Non-IPF, a lot of work is happening, it's so many, then I would say within the non-IPF ILDs, you have a fibrotic ILDs. Okay. Now, the antifibrotic therapies, as we are aware, are available initially only for the IPF patients. That's where they were approved. And now more and more data started to come in non-IPF fibrotic ILDs. And if you've seen the non-IPF fibrotic interstitial lung disease, there are many data which have shown that using antifibrotics in these other non-IPF fibrotic ILDs, antifibrotics have a similar benefit. Similar benefit is being seen. So therefore, if you have non-IPF patients who are on antifibrotics, again, what the antifibrotics have done is they have made us think about the not only the pulmonologists, but also the transplant pulmonologists also, to think about finding out what is the most suitable time when they can list the patient for transplantation and when they can transplant this patient. So again, it seems that the antifibrotic needs to be considered in a more special consideration. Again, the clinical predictors for survival of non-IPF ILDs include FVC, DLCO decline, hospitalization, frailty score. Urmil may discuss that. Oxygen use symptoms. Therefore, timing of referral and listing for lung transplant should take all these factors into account. Okay, that means you're looking at FVC, DLCO, hospitalization, the exacerbations the patient is getting, and of course, the trajectory that the patient has followed as since the date of diagnosis over the period of time. Now, specific transplant, maybe I'm not aware, but should we do transplantation for connective tissue disease ILDs? We know that CTD ILD patients have a better outcome. CTD ILD, even the UIP pattern in CTD ILD have a better outcome than an IPF UIP pattern. We know that. But should we be transplanting them? Because the issue is you have, whenever there is the extra thought that is given for connective tissue disease ILD is because these individuals have an interstitial lung disease, and along with the ILD, they have other systemic extrapulmonary organs which are involved. So those extrapulmonary organ involvement also needs to be taken into consideration. I think there are special guidelines which are going to be coming shortly, but I think there is a lot of data to say in selected patients, in selected young patients, it may be worthwhile to consider transplantation in advanced ILDs, even if connective tissue disease is there. And I would and Urmil is also seeing some of our patients with connective tissue disease ILD. Patients are well informed, transplant clinic is well informed, and I think there's a good coordination happening. And the patients also need to be, I would say, counseled in a way that it's an option. It may or may not happen to you. You may or may not be selected, but I think it's an option worth evaluating. Disease-specific consideration, that is now pulmonary hypertension. Pulmonary hypertension, I think I'll just briefly speak a few words. Pulmonary hypertension, primary pulmonary hypertension, idiopathic pulmonary hypertension has been initially one of the major indications for heart-lung transplantation. Then from heart-lung transplantation en bloc, it became apparent that even if you do bilateral lung transplantation, the heart remodels, then you come to bilateral lung transplantation. The question is, in these patients with primary pulmonary hypertension, when do you refer them for lung transplantation? That is, and typically they will need a bilateral transplantation. Again, the criteria are the same. You need to see, now you have an ILD patient who's on antifibrotics, you have a pulmonary hypertension patient who's on pulmonary vasodilators and other supportive treatment. As long as, if these patients are declining on the therapies, again, in these patients also the 6-minute walk test distance is coming down, if the breathlessness is coming down, if there's hemoptysis, I think those are the points where, there's a point about referral and also listing which is there. But primary pulmonary hypertension patients, again, there's been a big impact about pulmonary vasodilator therapies. There's a big impact about combination pulmonary vasodilator therapies. And therefore, it calls for a more and more closer coordination between the pulmonologists in the community as the transplant pulmonologist to have an appropriate discussion about listing. But the point is referral. I think the referrals for any ILD patients who's advanced, any patients with severe pulmonary hypertension, or any advanced disease, lung disease, which might eventually be a suitable candidate for transplantation, we need to move to a concept where, the transplant clinic is aware of it, the patient is touched upon it. Meanwhile, you can try to maintain the patient on conservative therapy, but I think a lot of these points can be touched upon. LAM is another thing. I don't want to go into the discussions, but again, lymphangioliomyomatosis is one of the conditions where you could think about transplantations and referral in patients with LAM. When do you want to refer them? You have several patients who are LAM, who are on your everolimus, sirolimus, they're holding on quite well. When do you refer them? You think about them, again, the same thing, the physiological deterioration or a diagnosis they're physiologically very low. You might want to refer them upfront. Or if they're deteriorating, if there's hypoxemia test, if the pulmonary hypertension is there, the pulmonary hypertension is worsening. And we know that LAM patients get pneumothoraces and already they have cystic lung disease, you have a pneumothorax, the existing lung is also not working well. So if you have a refractory pneumothorax, that can also be a problem and maybe a reason why you might send them to a transplant clinic for evaluation. Thoracic malignancies, so I think all of us, as families, always patients will ask you, so isko transplant kar sakte hai kya? I think transplantation is, I will just give you a brief, my understanding, we can refer them for transplantation if there's carcinoma in situ, very minimal carcinoma, adenocarcinoma, and where the oncologist is absolutely clear as far as the cancer is concerned, it is purely cured. The reason this becomes important in patients with COPD who are smokers who may have cancer. So we are talking about an underlying lung disease which might be suitable for transplantation. Okay, but then you identify lung cancer. If it's a small nodule, if that's been taken care of, so again, this is a special situation, and I think only centers of expertise should probably consider, or with a special expertise, a high volume, high experience centers should consider about transplantation and take a decision whether these patients, and make sure that particular cancer has been cured, and the oncologist should feel that the chance of recurrence is very, very less. So I think that's my last talk. Thank you very much, Unmil, for this invitation. Thank you very much for the HL team for asking me to come here, and we'll discuss later on. Perfect. Thank you very much.
So thank you very much, Dr. Chajat. It was a very insightful talk. Again, so I think take-home message over here definitely is timing and thought process of thinking of lung transplantation is very important. Don't wait till they're on their crutches and then start thinking about transplant. So we'll take up questions in our panel discussion a bit later. So I would now like to invite our next speaker, who's Dr. Prahlad Prabhudesai, who's going to talk on pulmonary rehab in ILD. No. So again, Dr. Prabhudesai needs little introduction. He is one of our leading chest physicians in the city. He's well known all over the country as well. He's primarily based at Lilavati Hospital and Research Center. He's been honored with more than 55 publications in national and international journals, and he's also written books on respiratory medicine. He's a member of the Indian Chest Society, a fellow of the American College of Chest Physicians, and a member of the European Respiratory Society. He's a postgraduate teacher for DNB, chest medicine, and he's also the course director for bronchoscopy at IMMAST, and he's also the director of Pratibha Prabhakar Pulmonary Rehab Center. So we welcome Dr. Prabhudesai to talk to us about pulmonary rehab in ILD. Thank you.
Thank you very much. Good morning. Thank you very much, Nimish, and thank you, Unmil, for giving me opportunity to communicate with you all regarding the role of rehab, especially in ILD and transplant patient. Because today's predominantly we are going to discuss the lung transplant, and most of the patients for the lung transplants are ILD. I just discussed with the Unmil that in our country, predominantly we get transplant. ILD patients get transplant, referred for transplants. And Dr. Prashant has told you regarding the indications for lung transplant. I can say that if you are a lung transplant patient, if you are referring a lung transplant patient who is on ICU on ventilator, after the transplant is likely to come on ventilator and obviously will be in ICU for a prolonged period of time. If you refer a patient who goes to a transplant center on wheelchair, he will come out on wheelchair. And if your transplant patients go walking to a transplant center, chances of him coming walking is very high. So in short, if you see, okay, you have to mobilize your patient, okay, before your transplant, whatever way. If he's in critically ill, still he requires a rehab in ICU for keeping him more fitter for a better outcome. If he's sick, we have to see that you have to make him at least stand and walk. And if he's walking, we have to improve his conditions much, much better before we refer to the transplants. And hence, for a transplant to have a good outcome, a rehab is extremely important. majority of the physicians or even the general practitioner still thinks that there is no difference between the rehab and physiotherapy. Physiotherapy is much and the rehabilitation, there are a lot of difference. Okay, that's very important. Physiotherapy is predominantly breathing exercises and secretions mobilization, etc. Well, rehabilitation is much beyond that. We all know that there are many interstitial lung diseases, okay, and there is an inflammation and fibrosis, and some of them are progressive. Treatment is anti-inflammatory, anti-fibrotics, and there is non-pharmacological therapy and lung transplant in selected patients. And rehab plays an important role in all the ILD patients. If you see the impairment in ILD, okay, dyspnea, cough, fatigue, exercise intolerance, reduce your quality of life, okay, and exercise-induced hypoxemia, all these factors are definitely get better and improved after pulmonary rehabilitation. So in ILD, okay, the lung inflammation and fibrosis and alveolar capillary membrane thickening leads to a restrictive disease and impaired gas exchange and hypoxemia. And pulmonary vascular remodeling leads to a pulmonary vasoconstriction and pulmonary in the capillaries. So these patients, will have you can say rehabilitation and oxygen therapy will give a really significant amount of improvement and improvement even into by improving the cardiac function and after during the exercises, and the muscle improvement, okay, improves the skeletal muscle function, will finally lead to decrease in the dyspnea, decrease in the exercise intolerance, and overall reduction in the dyspnea and reduction in the exercise, better improvement in exercise intolerance, leads finally a good quality of life in all this patient after preventing the deconditioning of the respiratory muscles, respiratory and skeletal muscles. All these increased breathlessness lead to reduced activity, social isolation, and anxiety and depression. And pulmonary rehabilitation plays a great role in reducing the breathlessness, improving the exercise intolerance, improving exercise performance, and decreasing the isolation and making the patient more self-confident, and hence why the quality of life of the patient significantly improves. What is rehabilitation? I told you the difference between the physiotherapy. Now, what is rehab and the rehabilitation? Now, what is rehabilitation? Is a comprehensive intervention based on thorough patient assessment. It's individualized, tailor-made, and just not related to exercise, training, education, and behavioral changes, but it's designed to improve the physical, psychological condition of a patient, chronic respiratory disease, promoting a long-term adherence to the health-enhancing behavior. And that's pulmonary rehabilitation. There's enough evidence, Cochrane evidence on COPD about the rehab is concerned. Okay, it's well established. And 2021 also shows there is a significant evidence to say that ILD pulmonary rehabilitation, there is a significant improvement in the patient. So there are many studies, they are lesser compared to COPD, but there are studies on IPF, there are studies on sarcoid, and there are studies on other ILDs, occupational ILDs. And finally, the age group here is between 36 to 72. And all these 21 studies, basically they are endurance training and muscle strengthening studies. The duration of being 8 to 12 weeks in 2 to 3 sessions per week. What the results is, first of all, rehabilitation ILD is safe. That's very important. Okay, and there is no really adverse effects happening because of rehabilitation. That's number one. It brings about significant improvement in the functional as well as the maximal exercise capacity, health-related quality of life, and reduction in dyspnea immediately following pulmonary rehabilitation. Effects last for 6 to 12 months. These are a Cochrane review data. And these improvements are similar in IPF when we compare with other ILDs. There is certain differences that the health-related quality of life dyspnea sustained to around 6 to 12 months, but not the 6 minutes walk test. So that's the only difference that if in IPF and other IITs. Okay. The improvement in 6-minute walk test following pulmonary rehabilitation was much similar in those patients of COPD and those patients with ILD. So this is something which is new, that even interstitial lung disease patient, if we refer for pulmonary rehabilitation, they get significant benefit. Well, we have conducted a study in our center, okay, which is published in JAPI in 2017, and we had almost 137 patients which were enrolled. 100 patients had completed the program. This is predominantly ILD. All ILDs were included, and aerobic training, strain training, breathing retraining, and educational activities were done. Duration of program was 8 weeks in our center. And we found this is done by physiotherapy. One more important thing, that a pulmonologist has got a very little role to play in these rehab centers, remember, except the patient selection, patient education, and making an awareness about rehab. It's predominantly done by the physiotherapists, or we can say that cardiopulmonary physiotherapists who are specialized in doing rehab. So here there was a significant improvement in the 6 minutes walk test distance, dyspnea, fatigue, emotional, and overall total improvement was there when the CRDQ questionnaires were given to the pre and post rehab programs. So even the muscle strength of bicep, tricep, shoulder flexors, shoulder abductors, quadricep, and hamstrings were shown significant improvement. Okay. Now, what exactly are the components of rehab? Okay. These are the standard components of rehabilitation. Outcome assessments is what? Is an assessment of the patient before entering the rehab and after finishing the rehabilitation. Education is an extremely important part. Now, this education is a constant process. It is not just one-time education. So throughout the program, the patient, initially the chest physician educate the patient, but most of the education is done by the ILD nurses and the physiotherapists. Okay, and this education is specifically to ILD. Okay. Then there is general exercise training. Okay, nutritional advice. Okay, that's extremely important, especially in ILD. Psychosocial support is much more required in ILD than COPD patient. And breathing retraining is generally, we say, a lot of benefits in COPD, but even ILD also patients get benefit of that. And obviously, then we assess the patient after finishing the rehabilitation. The very important thing is that these patients, we should not stop the rehab, but they have to be continued in the twice-a-week basis, or sometime in center or on web-based program. We should keep them engaging. We call them booster programs, okay? So that the benefit of rehab continues to happen to the patient. Now, how the delivery of the pulmonary rehab program is done? The first important role of chest physician is selecting your patient, assessing your patient, optimizing the patient with medical therapy, understanding the comorbidity of the patient and treating the comorbidity, giving references to correct people for treating the comorbidities. And once the patient is being optimized, we select whether easy fit for going for a rehab or not. And this is the role of chest physician. Then patient referred to a rehab center where physiotherapists take care of the patient, and her assessment is different. Okay, she has got to understand the exercise capacity, strain, health-related quality of life, and that is a role. Then in exercise training, it contains warm-up exercises, cooling exercises, strength and endurance, breathing exercises like diaphragmatic breathing, pursely breathing, dyspnea-related positions, okay, and breathing. These other exercises are also important in ILD, as we say that in COPD. Psychological support, yes, the most important support is given by the physiotherapist, but in selected patient, you need a psychological assessment and counseling. Yoga and relaxation techniques, pranayama, has got a great role, and that we realize in COVID time. Okay, the patient support groups are here important, and group discussion and group exercises are very important for a psychosocial support. educational activities about the disease and its relation to symptoms, especially related to ILD is very important. And in ILD, what is very important is educating them about oxygen therapy. There is a fear about oxygen, but this is an important part of education. Nutritional support, okay. Remember, all these patients have got on antifibrotics, they have got upper GI problem, sometimes lower GI problem, they lose weight because of the fibrosis and hypoxia. So the nutritional support is much, much more important compared to COPD. And these patients are referred for a proper medical nutrition therapy. Smart education, smart eating techniques, approaches have been followed for a good calories and high protein diet to them. Then post-program assessment after finishing the program, then maintenance booster program, and sometimes we refer them for a web-based program and home programs in selected patients. This is how the program is. As well as the assessment is concerned, the physiotherapy assessment, the first assessment takes almost 1 to 1.5 hours, where detailed history is taken, which is different from a chest physician taking a history. Remember, the family history, family support, a personal history, oxygen usage, daily activity levels, comorbidities which are related to physiotherapy, okay, psychological status, all these are assessed by the physiotherapists. Clinical examination, important thing is just to understand whether each patient is having any breathing patterns, how they are, oxygen usage, how she's doing, hemoglobin level, edema, sleep pattern, okay, then pain, if it is there or not, and special approaches to the, especially in collagen vascular disorders are required, because these patients have got other neuromuscular issues, and gait, posture, everything is important. So this is assessed by physiotherapists. And a rehab goal is put for the patient. This is highly individualized. There is a short-term goals, a long-term goal, and these are all goals to be realistic. Okay, every patient wants the oxygen should go. But this is something which is important to understand the patient, that oxygen therapy is not just as a conflict for the that you are worsened, but it is basically a type of treatment to the patient. So this is very important, and these are required. A proper goal is set to the patient, and then patient goes for the program. Okay, so as well as the patient education is here in ILD is concerned, is better understanding the overall condition of the patient is important. He has to be educated about that, not only just about the disease, but the complication of the disease and the future about the disease, and everything is being educated over here. Behavioral changes, including symptom awareness, is done. And again here, the influences of clinical outcomes in patient is also suggested. Vaccination programs, any addictions are there, then that should be, de-addiction, etc., is overdone over in education program. As well as specific ILD targeted education is concerned, the pathophysiology of ILD, management symptom, clinical tests which are required, autonomy, oxygen usage, especially why it is important to use oxygen while eating food is very important. And generally patient avoid all those things. So we have to tell them regarding the correct role of oxygen therapy. Similarly, the medications which they are taking, and they have their side effects. The first contact in rehab program before the doctors are physiotherapists, and probably they also help them to how to tolerate the medicines and accept the some upper GI problem, and how to manage them by nutrition, etc., and all that, and timing, so that they continue the antifibrotics and accept some of the milder GI disturbances like mild diarrhea or even the upper GI problems. And end of life counseling is done very smartly. And I always feel that physiotherapies and rehab programs are the better programs to understand, give them the philosophy of life and philosophy of treatment. Okay, rather than calling end of life counseling, it should be how to live or longer and better with rehab programs, and that's very important to tell them. And that's the rehabs are the better place to tell all those things. Well, as well as pre-rehab assessment of outcome measure is concerned, there are many things, like incremental shuttle walk test, a 6 minutes walk test, cardiopulmonary. All those things are not really required and not possible because of many reasons. Okay, but 6 minutes walk test is the most important accepted test. And today there's a lot of literature coming on 1 minute sit to stand test. Okay, and that also can be done, and that we use in COVID time. Okay, especially when we have web-based rehab program. Okay, strength measurement is by a 10 repetition, maximum 10 RM, and this is the most suitable tool. What we realize, and as well as the pre-rehab assessment and outcome measure is concerned, this NIA, okay, by doing modified Bogue scale and MMRC scale are used, and health-related quality of life. There are highly specific questionnaires. There are chronic respiratory disease specific question, and we generally follow CRDQ for assessment of the patient. And some now we are recently starting highly specific questionnaires for assessment of the pre-rehab as well as the post-rehab outcome measurements. As well as exercise training is concerned, okay, aerobic training, resistance training, and flexibility training is important and is based on FIT principles. Okay, the frequency, intensity, time, and type. That's called FIT principle. And I don't want to go into the depth of it, but try to understand that this is something which is very important, as well as, and this is physiotherapy trend as per the individualizing the patient, 3 to 5 days a week, 80% average speed on 6 minutes walk test, 75% peak speed, and basically dyspnea rating 3 to 4 with modified Bogue scale. Time generally is 20 to 30 minutes, and continuous training standard mode of training. But in ILD patient, it is generally continuous is not possible because of the hypoxia and tachycardia, and you have to have in between the rest has to be given, and interval training have a better outcome. Okay, the mode is generally walking, cycling, or arm ergometry, treadmill, and then the progression. Okay, that is interval training to continuous training. That is how we proceed. Okay. These are all patients generally in ILD all the time. When you consider rehab, patient is on oxygen therapy, and either you can give a treadmill or ergometer or on walking or a stationary cycle. This is generally done with the oxygen therapy. And for the exercise training, strength training is concerned, the frequency, intensity, and all those things are individualized by the physiotherapist to the patient. And these are the TheraBands, dumbbell, weight curves for the strengthening. And these are the different exercises are done for the flexibility and stretching exercises. Okay. Well, as well as exercise prescription is considered specifically for ILD. In view of profound exercise-induced desaturation and heart rate and rhythm abnormalities, exercise should be carefully planned. That's very important. And that's a major difference in COPD ILD rehab. Okay. Frequent rest pauses and administered during the exercise so that required exercise intensity is achieved in patients with severe dyspnea. Now, this is something again unique for the ILD rehab, and which is not generally we see in COPD rehab. In patients with collagen vascular disorder, especially RA or even scleroderma patient and other patient, strength and flexibility exercise should be employed with the caution to prevent injury or aggravation of inflammation. Otherwise, many times such patients, when they go to rehabilitation, if you are not very careful, they have more musculoskeletal issues, and they stop coming to rehab, start blaming physiotherapy. After that, everything is started. So this is very soft thing, and the physiotherapists have to take care of all these aspects, especially when they are. As well as the supplemental oxygen therapy is concerned, I told you that this is something which is extremely important. COPD patients generally do not require oxygen therapy unless very advanced, but in ILD, the oxygen therapy is required if oxygen saturation less than 85%, and it can be given. There is something called oxygen titration, okay, which is done at the rest as well as when they are doing activity, so that we have to maintain saturation around 88%. Because if oxygen therapy is given, the dyspnea is less, the desaturation is less, effective exercise training is intensity is improves, less hypoxic pulmonary vascular capillary constriction happens, lesser afterload on the heart, and better heart function. So this is all advantage of oxygen therapy when you are using correctly, especially after titration of oxygen. And this is especially in Ireland, this is how we titrate by giving oxygen slowly. And if the oxygen requirement is less than 88%, despite of 6 liters of oxygen at rest, yeah, the patients are not fit actually for the clinic-based rehab program. Okay, and then probably we have to have some other alternative, especially if you're going to go for the left transplant. Same type oxygen therapy, you can titrate it on walking. Okay, and this is done. Okay, in our clinic we do it, and that's why we require plenty of oxygens over there, and you need a number of oxygen concentrators required if you have more patients. In our center, we are almost doing 35 to 40 rehabs a day. Okay, there are 6 physiotherapists managing the center, and the most important thing what is required is oxygen. Okay, in the rehab centers. Well, introduction of oxygen as a medication is important. That's why I said in education and ILD, this is very important. Need supplement. What are the positive impact of oxygen on dyspnea level, desaturation, heart functions have to be educated to them. Various oxygen devices has to be showed to them. The safety precautions, especially also important regarding swallowing while eating food, including breakfast, lunch, dinner. Why oxygen is important. Then daily activities, oxygen requirement, how it should be managed. Traveling with oxygen. A lot of our patients go abroad. In fact, I can say that at least in a couple of in a month, at least couple of my patients go to United States to move with their go there, and they are very easily can manage to go over there with an oxygen support. And oxygen machines should be advised to them. How we can, so when they buy the machines, we have to guide them correctly. Okay, so this is the education about oxygen therapy. This is the most important education they require. So the breathing retraining is concerned, that is breathing exercises. Generally, we say that they are important in COPD because there is a mechanical advantage if they do the pursed sleep breathing, diaphragmatic breathing, and other thoracic expansion exercise, because there is a mechanical problem. Whether this is important in ILD, yes, there are some controversies on that. There is a systematic review showing that adding breathing exercises to aerobic exercise training, especially improves the functional capacity, dyspnea, health-related quality of life than aerobic training alone. So these rebreathing techniques, you can say, are extremely important. There are some studies showing that that deep breathing exercises and pursed sleep breathing exercises are not useful in ILD. So there are few studies on that, but there are significant studies showing improvement. And if you see that Pulmonary Fibrosis Foundation, okay, Action for Pulmonary Fibrosis, Life for Pulmonary, all these centers recommend diaphragmatic breathing, slow deep breathing, and pursed sleep breathing. And we also recommend, because we have done a study on this thing, this is unpublished, but our clinical experience is that yes, they do get benefit by teaching them these exercises. Well, as well as nutritional advice is concerned, I think this is a difference in COPD and ILD, because in ILD patient, there are a lot of nutritional issues. They're already malnourished. Okay, they lose weight because of the medicines. Okay, and they have abdominal discomfort, bloating, loss of appetite, lose motions. All those things are important, and they either because of antifibrotic or because of the hypoxia. Okay, and the nutritional advice is very important. You have to call a specialized nutritionist, and she can give a proper nutritional advice. And the smart eating programs has to be implemented in them so that they don't lose weight on rehab. That's very important. And psychological support. This is something an extremely important difference between the COPD and ILD patient. They are always nervous, anxious, depressed. They're on oxygen therapy, and so there are so many issues they have, and there are so many reasons for them to go into a psychological breakdown. And for this patient, physiotherapists play a great role rather than referring to psychiatrists. But you need counseling and you need some support, and these are meditation. Great user. This is what we have recently found, that yoga and pranayama, which is our ancient methodologies, okay, improves their mind setup very well, sleep pattern very well, okay, and meditation, relaxation exercises, cognitive behavioral therapy, and support groups, especially in the center, okay, group of 4 people talking together, giving them programs about the enjoyment and other thing activities gives them a lot of psychological support. And this is a very important part of ILD rehabilitation. As well as transplant and ILD rehab is concerned, there's no doubt about that. I told you that if you want your patient, if your patient goes on, again I'm telling you, on ventilator bed, is going to come out on ventilator bed. If patient goes on wheelchair, is going to come out on wheelchair. If patient goes walking, is going to come on walking after transplant. So transplant, okay, is something, if we really would like to progress in our city and country, a rehab program should start. Okay, and this is the thing which once they are mentally and physically better, okay, the transplant results are going to be better. Okay, so there is nothing, no doubt about that. There is a improvement in the functional capacity, quality life, but reduces the risk of prolonged mechanical ventilation, ICU, and other hospital stay, especially in transplant patient. It has been shown that reduction risk of mortality is by 50%. Okay, if the patient goes on proper rehab program, and post-transplant program should be planned for at least 8 weeks. That's very important. Okay, so this is about transplant in short. If I, this today's talk, if I want to compare COPD rehab and ILD rehab, yes, there is altered pulmonary mechanics and function in COPD. So there will be a difference in COPD and ILD as well as the rehab programs are concerned and outcome is concerned. This could lead to differences in the strategies of rational terms, breathing retraining and supplemental oxygen therapy, etc. and all that. But there is a significant amount of similarities like cardiac dysfunction, skeletal muscle dysfunction is similar in ILD and COPD. Hence, muscle strength, endurance exercises, etc. and exercises could be really effective and they can increase the quality of life of this patient. And if your skeletal muscles are good, generally the patient's outcome is very good. Remember, it's not just respiratory muscles are important, but even your peripheral skeletal muscles also do play a good role in a quality life. There are so many differences are there. I don't want to go into depth, but outcome assessment is little different. Exercise training pattern is different. The breathing retraining I discussed with you, nutritional advice and it's patient education I told you. There's a lot more on oxygen therapy. Psychological support is much more required in ILD rehabilitation. Okay, so these are some of the similarities and differences. Summarizing my talk, rehab is the most promising and it's a non-pharmacological treatment of ILD. And there is a data on Cochrane today that it is satisfies as well as clinically significant improvement happen in terms of functional capacity, quality life, and dyspnea and ILD, including IPF. Okay, and it's safe. That's very important. We always feel that so much tachycardia is there in patient and hypoxia. Is ILD rehab is safe? It's safe. That is proven. So medical nutritional therapy is another important component of rehabilitation, which is very important along with education, especially in oxygen therapy, and psychological supports are equally important in PR and pulmonary rehabilitation. I think, thank you very much. Okay, if any questions are there, I'm ready to answer now. Yeah. Sorry? What is the compliance of the Yeah. When you select your patient for a rehabilitation, okay, this is all the first things we first find out from the physiotherapists, find out what could be a likely compliance of the patient. Okay, and when that's why for everything, for transplant, so you need some person who has to be motivated for transplant. Similarly, for pulmonary rehabilitation, especially in all this patient, there has to be some motivating person in the family who will take you for rehabilitation, and that's his job. So I can tell you that in our study of ILD, out of 137 patients, 100 patients completed our 8 weeks program. I can say that they later on followed 12 weeks also. 1/3 of our patients dropped out. Okay, despite of sufficient amount of education. So it is going to happen like that. But some of these patients do follow, but there are some issues. But today we have understood in COVID time that web-based programs are also very important, but they are taxing to physiotherapists. Okay, but we do at least around 5 to 6 daily web-based program okay, for not only for our Mumbai city, but abroad also, and for the all over India. We do that on web based, and this is a good way to maintain the rehab program. May not be as effective as a in-person rehab program, but if they're assessed properly, and if they come to a center and understand exactly about rehabilitation, then the maintenance on web base is not a bad idea. It's good, and it is going to be a future probably. I can say that, especially when there are lesser centers available in the city and country. Thank you.
So thank you, Dr. Prabhu Desai, for a very insightful talk into pulmonary rehab. And I think it's very important that you stressed on the message that pulmonary rehab is not only physiotherapy. It's a comprehensive, overall holistic approach to a patient's well-being. And I think that was pretty much the take-home message for me. I think most of us. So going with the flow from thinking about transplant to selecting your or identifying your transplant to literally mobilizing the patient to do transplant, we've taken the liberty to just switch our talks a little bit to go into preoperative evaluations in lung transplant first, and then we'll come to the most important bits of surgical considerations in lung transplant. So I would like to invite my colleague and the brainchild behind today's CME, Dr. Urmil Shah, who is our transplant physician at Sir H. N. Reliance Foundation Hospital. Urmil has pretty much been the pillar of the transplant program ever since its inception into the hospital here. He's worked day and night looking after pre-ops, post-ops, intra-ops. So Urmil is pretty much 13 years post-MD experience. He's worked in various reputed institutions all across the city. He's done his transplant pulmonology training from the prestigious Heart and Lung Transplant Institute at KIMS, Secunderabad. And his experience along with Dr. Atawar's team has been phenomenal. He's done multiple retrievals, evaluations, and I know because he takes away half of our burden. So all our pre-transplant ILD patients who badger us with WhatsApp messages, they've all been diverted to Urmil, thankfully. So again, Urmil has an exemplary CV as well. His special interests of obviously lung transplant and EVLP with interventional pulmonology. He's got various associations of memberships of IAB, ICS, the ISHLT, ACCP, ERS. And to his credit, he's also contributed to the textbook of transplantation and mechanical circulatory ventilation for end-stage lung and heart disease. So I would like to invite Urmil on that to begin his talk. Thank you.
So there's already some build-up
Thank you, Nimish, for the kind introduction. Coming to the next topic, which is the preoperative evaluation for lung transplant. And I always tell my patients that evaluation does not mean listing. There is a wide difference between when you are referred to a transplant clinic for evaluation, and this is a time where the physicians are pondering about whether you have a candidacy for transplant or not. So let's begin with the topic. Okay, so what are the principles for the evaluation? So a full evaluation includes assessment of lung disease severity, anatomy, nutritional status, degree of frailty, presence and severity of comorbidities, psychosocial circumstances, health-related behaviors that impact the recovery and long-term survival. And believe me, each and every word is important here. Sometimes you can have a precipitous decline, which leads to a panic situation among the family and the pulmonologists, which tend to refer, as mentioned by the previous speaker, the patient is on ventilator support, and now the only option remains a lung transplant. But in those situations also, I think every effort should be made, which whenever feasible, in whatever practical limitations what we have to assess the candidacy for the lung transplant. As we all know, double lung transplants have been the norm worldwide nowadays in the last decade or so as compared to single lung transplants. Coming to the concept of transplant window, and that is very important to understand for all the pulmonologists across, that you have a patient who has been following up with you for almost 6, 7 years, 10 years, patient has been stable, and then there is a certain turning point and there is a precipitous fall in the clinical course. Before that precipitous fall, you would definitely be able to find out or some telltale signs, symptoms where you would get an idea about whether the underlying disease is progressing, whether there is going to be an imminent, fatal precipitous decline. So if there is a rapidly progressive disease, if there is increase in the oxygen dependency, or increase in hospitalizations, I think these are the telltale signs, symptoms along the course of the disease, which would point the pulmonologist that probably it's time to think about transplant. And every patient would have a different transplant window. Some patients have a narrow, some have a broad window. So it's not that IPF patient is going to behave all IPF patients in the same fashion. And hence it is important to pick up that transplant window or the phase across the course of the disease. Doing too early transplants is doesn't help anyways, and doing late also it's not going to help much. So it's better to have a patient in a correct transplant window. There are some 50, 60 tests. I'm not going to discuss all those. I'm going to touch upon specific tests which are important from the pulmonologist perspective. So we do specific blood tests from the transplant perspective, like panel reactive antibodies, various immunological tests. We do detailed cardiac evaluations, whether it is right heart catheterizations or angiographies. We are very paranoid about gastro or GRD, and hence we do detailed evaluation in terms of pH metries, manometries, and sometimes gastric emptying scan. We do perfusion scan, which helps us, my surgeons, to decide on table which lung comes out first. We do various Dopplers, sonos, referrals, cultures, BMD DEXA scans, cardiac MRIs, and selective. And respiratory, I've kept it the last, because that is something which most of our pulmonologists are aware of. We do CT scans, pulmonary function tests, whenever they are feasible, 6-minute walk test distance, USG test for diaphragms, and blood gas analysis. Coming to the first aspect, which is the cardiac assessments, but natural, we do 2D echoes, ECG, and very important concept of right heart catheterization, which is nowadays considered as a gold standard for measuring the pulmonary artery systolic pressure, the mean PSP, and other cardiac hemodynamic parameters, and I will be coming to it why these parameters are important. We do angiographies preferably above the age of 45 and cardiac MRIs in select field. Coming to the first, why do we require right heart cath when we can get a PSP on 2D echo? Across the studies it has been documented that elevated pulmonary artery pressures have consistently emerged as a strong risk factor for primary graft dysfunction. Primary graft dysfunction means it's a condition in the first 72 hours after the implantation where patient ends up in a non-cardiogenic ARDS kind of a pattern, and patients might require, some of them might require ECMO. So it's a condition which has a significant correlation with the mortality and the morbidity in the long-term post-transplant care. So it has been found that echocardiographic estimations of the PSP and the direct measurements of PSP by the right heart cath, they have a moderate, association. The echocardiographic measurements sometimes are inaccurate. They tend to overestimate the real PSPs by more than 10 millimeters of mercury in 1/3 of the patients. And they also tend to underestimate in 1/10 of the patients. It was also found in various publications that echocardiography was found to overestimate in almost 60% of the patients. Also, in one of these papers published in BMC Cardiovascular Disorders, it was found that the echocardiographic PSP measurements were moderately discriminative to pH. Sometimes you don't get TR jets in the echoes because of the poor window, and that absence of TR does not preclude elevated PSP. So it was recommended in this study that performing routine RHCs to all lung transplant candidates, regardless of echocardiographic estimations of PSP or presence of TR jet. So why are we fussy about these values? Because there have been papers published a decade ago in CHEST where it was shown that elevated pulmonary artery pressure is a risk factor for primary graft dysfunction following lung transplantation. So if we have a mean PAP which was higher in patients who developed PGD at 72 hours, almost 38 millimeters of mercury plus minus 16 was found to have increased risk of mortality and morbidity. The increase in the odds of grade 3 PGD for each 10 millimeters of mercury increases in PAP, in the mean pulmonary artery pressures. And the graph to the left, we can always appreciate and see that as the mean pulmonary artery pressures rise, the risk for PGD increases. Another paper, landmark paper, which was published in Journal of Thoracic Disease, and it was found out that the mean pulmonary artery pressure, accurate measurement, does have a prognostic value. The 1-year survival rate among patients with mean pulmonary pressure above 25 was lower than the survival rate among patients with mean pulmonary pressure less than 25. And that's why it becomes important to have an accurate value which we can only get on right heart catheterizations. So this is the report, how it looks like. I will just enlarge it. This was a recently done right heart cath where we have various parameters calculated in terms of the RA mean, the RV systolic, diastolic, and the mean pressures, the PA systolic and diastolic. Here we have a PA systolic of 104, which almost is like a systemic PA pressures, the transpulmonary gradient, the PVR, which is calculated in the right heart cath. And this is how we get various hemodynamic parameters to decide and to set the candidacy for the transplant. Do all patients require MRI? No, but their cardiac MRI is helpful in selective, in advanced end-stage lung disease patients with severe pulmonary hypertension and RV dysfunctions. It is also helpful in Eisenmeinger's and advanced high pH. What does cardiac MRI do? It helps us decide regarding whether the patient would go for a combined heart-lung transplant versus a bilateral lung transplant. And across the world, the transplant centers have different protocols, but they seem to agree among the various protocols that if the cutoffs below which the double lung transplant is deemed inappropriate would be somewhere from 10 to 25% for RVEF, which is a parameter which is easily calculated on cardiac MRI. And there is a literature that RVEF parameter is a stronger predictor of mortality in PH patients, even a stronger predictor than mean pulmonary artery systolic pressure. And also the cardiac MRI would give us a value about LVEF, which would be anywhere, if it's below 50%, we have to think about combined heart lung. RV systolic function and dilatation are hallmark determinants of outcome in PH, yet chronic RV pressure load results in RV myocardial stiffening and fibrosis. Stiffening and fibrosis may be potential contributors to the disease severity and outcome in PH, and this helps us guide us about it shouldn't happen that you have an advanced IPH patient, you go for a double lung transplant, but post-operatively you encounter cardiac complications and which impacts the outcome. And it's very important. So this is a patient where it shows that you have a cardiac MRI finding in a patient of PH, the RV and the RA on the picture A shows severely dilated and there is a septal bowing towards the LV. And the picture B is the cardiac MRI report post-lung transplant. Here, it's not a combined heart-lung transplant, it's post-lung double lung transplant where you can see the RV remodeling back, decreased in size, and the IVS is restored. So that is how the patient of IPH can benefit from double lung transplant, provided an accurate assessment pre-operatively has been done. So not all IPH patients require combined heart-lung transplant. This is the message which I would like to put across. So again, this was a paper published that we have these parameters of whether it's the right ventricular and diastolic volume or ejection fraction, whether it's the RV LV volume ratios. Every all of these parameters tend to improve in select few patients, those who undergo double lung transplant in patients of advanced pulmonary arterial hypertension. So this was a recent case. We did an evaluation, practicing GP from UK, 46-year-old who came to Mumbai, already had a working diagnosis of scleroderma systemic sclerosis with ILD, end-stage lung disease, severe PH. We got an echo which showed an RA-RV dilated TAPC of 20, which is not bad. RVSP of 112, which is indicating a systemic pulmonary artery pressures, LVF 55%, subtle interventricular septal flattening suggestive of mild RV pressure and volume overload. I got a right heart cath done. RA mean 6. RA above 15 indicates a very high severe PH and a predictor of mortality, but RA was here 6, which is fairly okay. But PA pressures were high, 104 systolic, with mean of 61. For those who probably may not be aware, the pulmonary arterial hypertension definition on a right heart cath is any pressure above 20. The mean pulmonary artery pressure above 20 is the definition of pulmonary arterial hypertension. But here it was value of 61, which indicates a high severe pH. Cardiac index of 2.1, fairly okay. The impression was normal biventricular filling pressures, severe precapillary pH with moderately reduced cardiac output. Should we go for MRI? Yes, we went ahead. And MRI just was, the MRI findings baffled us that, looking at the RHC, we thought that probably the patient might benefit from a double lung transplant because RA is 6, a cardiac index is 2.1, fairly okay. But when we did a cardiac MRI, it showed marked RV hypertrophy with dilatation. LV was severely compressed by the hypertrophied and dilated RV and bowing of the IVS to the left. Both the end diastolic volumes were reduced, but more on the left. The depressed RV and LV systolic functions with RVEF of 18%. As I've documented in the earlier slides, RVEF less than 25%. Most of the transplant centers across the world tend to favor combined heart lung. LVEF, mind you, here was 40%. Now, if you see the 2D echo finding of LVEF, it was 55%. Yes, a normal EF on the LV, but here on the cardiac MRI, it showed a dip in the LV, RA dilated. Another important factor, what we found finding was the focal intramural LGE fibrosis noted at the LV insertion points, and there is a literature which suggests that any LGE and enhanced, that is a late gadolinium enhanced fibrosis, which is there in the RV, it is an indicator, a poor prognostic indicator, and a severe of mortality in a patients. And those who have these findings, they say that the survival for PH patients is less than 5 years. So all these findings made us to come to a conclusion that the patient would go for a combined heart lung transplant and not double lung. Had we would not have done cardiac MRI, if you would have gone for a double lung transplant, you would have encountered a bad RV post-operatively, which would have predisposed patients to land up in VA ECMO. So hence, it is important to have accurate assessment of the pulmonary arterial hypertension. And this is what the video also which showed. And if I don't have a pointer, yeah. So if you see this is your RV, which is markedly dilated. We have a LV, which is small, underfilled, and this is how the cardiac MRI video looks like with the IVS which is pushed to the left. So coming to the next gastro, again, we are paranoid about GRDs, as I told. So we have an extensive evaluations done by our gastroenterologists. We do USG abdomens, pelvis, we do 24-hour pH metries, impedance testing, we do manometries, gastric empty scan, and rarely bronchoscopies with PAL. So GRD, why are we interested in it? Because the pre-transplant GRD is associated with worst allograft function and survival post-transplant. And that is why we are very aggressive about GRDs. And GRD, as our pulmonologist colleagues know, they are also one of the commonest risk factors for various respiratory exacerbations in underlying end-stage lung diseases. Post-transplant GRD also has been shown to increase risk of acute rejections, pulmonary infections, and predisposing for something called as chronic rejection or chronic lung allograft dysfunction. So hence, assessing GRD, it becomes a crucial point in the preoperative assessments. Again, one more study which showed that pre-transplant GRD was associated with decrease in FEV1 early after lung transplant, such that, this is the important line, that by 18 months, it was found that FEV1 was 70% of the predicted in double lung transplant patients with GRD versus 83% in those who did not have GRD. Also, it was found out that a similar decrease was observed in single lung transplantation where they had poor survival post-transplant. And this is the Kaplan-Meier survival graph, which it shows that if you have a double lung transplant, no GRD, vis-a-vis a double with a GRD, the survival is reduced, the FEV1 drops. And again, with the single, no, and with the GRD basically it influences the lung function. And once you have a drop in the precipitous drop in the FEV1, if you see the graph on your right, the survival also reduces. So hence it is important to maintain and have a stabilization of your FEV1s post-operatively as well. So what are the tests we do for GRD? We do 24 hours ambulatory pH metries, impedance, esophageal manometry, and rarely OGD scopies. The most accepted definition of GRD during pH monitoring has been defined as a sudden decrease in the intra-esophageal pH to below 4.0, with the nadir pH being reached within 30 seconds from beginning of the drop. So this is just, I'll just rush on to this. This is ambulatory pH catheter placement, what my gastroenterologist does, and we get these various values in upright position and recumbent position, proximal, distal to the LES sphincter. So this is how it is interpreted. We do high resolution esophageal manometry, which is a technique to determine the function of esophageal musculature and the integrity of the lower esophageal sphincter. It is regarded as a gold standard investigation for mobility disorders of esophagus, and believe me, most of these patients who have end-stage lung disease do have hiatus hernias because of the various, the chest wall physiological changes which have underwent because of the restrictive lung diseases, which does impact your LES as well. Manometry is also commonly performed before anti-reflux surgeries to exclude other disease diagnoses as achalasia, which may present with reflux-like symptoms, and to exclude major weaknesses in esophageal peristalsis. And this is more relevant also from our scleroderma patients, which are a subset of patients which are referred to us as well for the transplant. And they are, believe me, a tough subset to tackle. So you have, this is how the ambulatory pH metry works, and this is the report for the manometry. I wouldn't go in detail of those, but this was a paper which was found that improved lung allograft function after fundoplication in patients with GRD. So what do we do about GRD? We are not going to do a fundoplication preoperatively because most of our patients are end-stage lung disease. They are on high oxygen support. It's not possible to, do such complicated surgeries preoperatively, but we have had few patients who have undergone lab fundoplications here in our hospital at HN, and they have been doing remarkably well with stabilizations of FEV1 and improvement in the symptoms. So if you see here the graph, the pre-fundoplication, the FEV1, and you can see the jump, a significant jump in the FEV1 post-fundoplication, and hence it's important to have an accurate assessment. Coming to the third aspect, we do lung perfusion. This is the report of the same lady which I discussed you earlier. It showed bilateral small to large variable size segmental and subsegmental lung perfusion defects involving almost all the lobes, predominant involvement of the right. So right lung perfusion was 36, left lung 64. How does that help? It helps my surgeons to decide which lung comes out first or gets explanted on table. And here the most diseased lung, but obviously would be explanted first. Coming to another very important test, and all pulmonologists across are aware about this test. We do 6-minute walk tests, and it has been significant in important marker of mortality, which predicts survival post-transplant and has been incorporated into transplant evaluations on a continuous basis. So walk distance has been associated with waitlist mortality in patients with end-stage lung disease awaiting transplantation. And this is a data which is as early as in 1997, which was published in Journal of Heart and Lung Transplant, that it was shown that a 6-minute walk test result of less than 400 meters appears to be a reasonable marker with regard to a patient when patient should be listed for transplant. But believe me, this is not the only parameter which we think, which we decide upon. There are various other parameters which we go through before we decide about the candidacy. Again, this was a beautiful paper published, which has shown that walk distance is associated with the post-operative survival following lung transplantation. Again, this was a paper published recently in 2017, just 5 years back, which came out with an important conclusion that a walk distance less than 180 meters has a lower survival post-transplant. Walk distance, but not the oxygen desaturation, was significantly associated with post-transplant survival. Because, we are dealing with end-stage lung disease patients. They are all going to desaturate. So more than oxygen desaturation, the walk distance takes the precedence in deciding about the candidacy for the transplant. Another specifically blood test, what we do is a panel reactive antibodies, which we are very cautious about, is because what are panel reactive antibodies? This is just one slide to touch upon to sensitize pulmonologists across. This is the presence of antibodies to HLA antigens prior to transplantation. And why it is important? Because those patients who have high PRA, more than 25%, they have a decreased median survival because it increases the chance for rejection for developing antibodies to the allograft. Coming to pulmonary rehab, again, I don't have to elaborate much because my previous speaker has, has explained in detail. So PR, pulmonary rehab, we focus more on pre-operatively as well as post-operatively. Exercise capacity training volumes are well preserved among lung transplant candidates who have been participating in pulmonary rehab. Participants with greater exercise capacity prior to transplant, tend to have more favorable outcomes post-transplant. Again, this was a Kaplan-Meier survival curve, which showed that in the pulmonary rehab group, there was a better probability of survival as compared to those patients who were not very active on the pulmonary rehab. Frailty, again, this is a parameter which we have started calculating in our Center for Pre-Transplant Evaluation. So there is a lot of data coming up in the last 5 years or so about preoperative frailty, because it is associated with a tenfold increase in the risk of death within the first year after transplant. So I will be elaborating what this is in my next slide. So SPB, which is a short performance physical battery, it's a scoring system, which is usually done by my pulmonary rehab physiotherapist. And this index is a validated index. It has been shown to be associated with increased risk of mortality at 1 and 4 years. So this is a battery of tests what have been done with various scoring systems to calculate, and we get an SPB score for our each and every preoperative patient. If you have a score less than 7, which means it fits into the definition of frailty, and this is a very important test which my pulmonary rehab physiotherapist does. Again, SPB, if you see the graph on your right, the SPB correlation with the survival, to those who have a less than 7, those who have a high frailty index, they tend to do poor in the post-transplant period. What are the other evaluation aspects what we are looking to? The BMIs, we calculate more than BMI more than 35 is an absolute contraindication for transplant. Between 30 to 35 is a relative contraindication, and hence we have to be mindful about the BMIs. The nutritional status, we usually have long discussions with the dietitians to build up their nutritional status, achieve the calories and the proteins which are required, because most of our end-stage lung disease patients have significant loss of weight. Functional status and frailty, which I have already discussed in my previous slide. Psychosocial evaluations, again, very important for the lung transplant candidates, because they are the guys who are going to endure ultimately all the pains, all the the troubles post-transplant, and hence it is important to have a good mental motivation to understand what they are entering into before just going into the surgery. So the psychosocial evaluation, here we do evaluations by the psychiatrist as well as the psychologist. So both are into the pre-operative evaluations to assess. We have a CPAT scoring, which is a Stanford scoring system, which is validated for the transplant settings. And obviously we take IDOVIA evaluations, infection disease specialists, to run through various cultures to find out if those patients do not have any drug resistant bugs or some bugs which might influence the outcome post-operatively. For example, presence of Mycobacterium abscessus or presence of Burkholderia species. Some of the centers do not touch those patients for the transplant, and hence it is important to have a strong ID evaluation plan. So my take-home message would be a rational, judicious approach for pre-operative evaluation. Evaluation does not mean transplant, or evaluation does not mean listing. There is a wide gap between the two, but evaluation should always happen early on, because it gives early referrals, always give time for the families to be ready, for the patient to be ready, and also for the physician who is managing the patients to optimize those patients to reduce the risk factors before they go on table. Pulmonologists should be aware of such factors as to optimize patients referred for the transplant training. And hence, why we discuss these parameters, because it's even the pulmonologist across can optimize on these parameters before they refer to a transplant clinic. And ultimately, pulmonary rehab becomes an important tool pre-operative. Thank you.
Thank you, Unmil. That was very insightful. And I think now moving on from pre-op evaluation to the real deal, which is surgery for lung transplant. I would like to invite Dr. Sandeep Atawar. Okay. So Dr. Sandeep Attawar needs little in terms of introduction. He's a very well-known surgeon. He's the director of lung transplantation at Sir H.N. Reliance Foundation Hospital. In his career of 21 plus years of experience, he's participated in over 10,000 open and closed heart surgeries in adults and children, lung and heart transplantation in adults, LVAD assist devices for failing hearts, and is capable of performing a variety of surgical procedures on patients of any age, from neonates to octogenarians. Dr. Attawar and his team performed 30 successful double lung transplants on patients with end-stage COVID-damaged lungs. And I think this was pretty much the silver lining that we had when the COVID pandemic hit us, because that's the only thing that we could do to salvage our patients. 380 plus total transplants, 241 double lung transplant, 96 heart transplants, 46 combined heart and lung, 44 LVADs. Dr. Attawar is recognized for his ability to perform a variety of complex cardiac procedures on patients of all ages. For those under his care, they enjoy a high level of satisfaction that is in line with his exceptional results. He also expertises in beating heart CABG, LVADs as discussed before, heart and lung transplantation, complex corrections for congenital heart disease, heart valve repair or replacements in adults and children, reoperative cardiac surgery, and minimally invasive heart surgery and cardiac surgery, both in adults and pediatrics. So we invite you, Dr. Attawar, to take this forward. Thank you.
We'd like to thank you, Nimesh, for a very generous introduction. Thank the audience for your presence here, previous speakers for the discussion and their wisdom on the subject, and the audience for your time. And probably try to keep this brief. The entire intent is to try to make it as simple as possible so that it's easy for any physicians here in the crowd who understand as to how their patients would be evaluated or assessed when they go forward with lung transplant, the challenges that we face when looking at transplanting patients who are seriously sick. So I'll start with the first slide. I was fortunate to be on this very esteemed panel of experts. 24 of us chosen 2 years ago to set up the consensus guidelines for the selection of patients for lung transplantation by the International Society for Heart and Lung Transplant. This consensus document comes out once every decade. It sets up it is the practicing Bible for selection of patients for lung transplantation. And we set it up during the COVID era. It was a difficult time, and we intentionally decided not to focus on COVID at all. And so our supplementary paper for the selection of patients who had undergone lung transplantation of COVID, and the way we select them would happen in the future, probably in the next 2 or 3 years till we get validated data. So when you're looking at selecting patients for lung transplantation, as Gurmil just mentioned to you in significant detail, we also must always never forget that there are some ethical principles for the utilization of and the allocation of donor organs. The most of it is utility, which all my previous speakers spoke about. It's to maximize the net benefit of that donated organ to a recipient who requires it the most. It's also important to do it with justice. We have to be sure that we are distributing the benefits and the burden of the organ allocation system in a fair way, that we will prioritize allocation to the patients who are the sickest, who will have the greatest amount of benefit, who will have an advantage as far as their life being saved, and also with a great deal of respect to the person who decides to undergo lung transplantation. Doing a lung transplantation against his choice is unfortunately sometimes a waste of the organ. So informed consent is crucial. In general, what are the recipient considerations? It's important to also know that we follow some very simple criteria, and we should subject those patients to lung transplantation only when they have a greater than 50% risk of death due to their lung disease within 2 years if a transplant is not performed. At the same time, we should be sure that more than 80% survival is possible in these patients for at least 3 months after a lung transplant. Anyone who's probably in extremis, who probably is not going to do extremely well with that organ, is probably the last candidate you must consider. But there are exceptional circumstances to it. As far as the possibility, that is the more than 80% chance of these patients being alive at the end of 5 years after a successful lung transplant, is also one of those guiding principles to perform a lung transplant. That is because we are allocating an organ which will serve somebody for almost the averaged median survival of patients who have undergone lung transplant across the world. So let's begin with some absolute contraindications. So when would you not consider a patient for a lung transplantation? I think that's important. First of all, when the patient or the family is unwilling for it, or he's had a malignancy, or probably even recently treated malignancy with a high-grade tumor which has a great chance of recurrence, simply because immunosuppression would drive everything out of whack. Patients who have a glomerular filtration rate which is significantly reduced, unless you're looking at a combined organ transplant, a lung with a kidney. A patient who has had a recent MI or a significant myocardial event within 30 days is probably not somebody that you would consider for a double lung transplant. Somebody with an extensive stroke within a period of a month, somebody with liver cirrhosis or exhibited portal hypertension or synthetic dysfunction of the liver, unless you consider them for a dual organ transplant. We have patients who require a liver and a double lung together, patients who have had acute liver failure, or patients who have had recent renal dysfunction with a persistently increasing creatinine level. Somebody who was infected, probably in some degree of septic shock, active tuberculosis, HIV infection with detectable viral numbers, patients who probably have very limited functionality or rehabilitation potential after surgery, maybe an elderly gentleman with both knees in bad shape, probably with multiple other reasons why he would not rehabilitate, would not be a great candidate for a transplant in the first place. People with progressive cognitive impairment, an inability, probably early Alzheimer's or any kind of motor neuron disease, which probably would be a clear contraindication. We must understand that these guidelines are set with the simple goal of not trying to do more harm, and also making sure that that organ could benefit someone else who probably is a better candidate, which would be a utilization of resources in the right way. Also, those patients who have exhibited a clear non-adherence to medications on their therapeutic follow-up. So people who have addictions like vaping, or they have current tobacco use, or are unable and lapse very frequently back to smoking or the use of tobacco, or any other medical condition which is expected to limit the life of the patient after a transplant. Then we come down to the second category. Now, how this guideline was different from all the previous guidelines was we did not have absolute contraindications and indications. We broke it down into 3 different levels. We had something which we said you sensibly would not do a transplant, where we grouped it as absolute contraindications. Then we brought in the middle or the high risk category. Anyone over 70 can technically undergo a transplant, provided everything else that Urmil said falls in place. Anyone who probably has coronary artery disease, if they have enough time before you subject them to a transplant, would probably have percutaneous angioplasty for 1 or 2 lesions, followed by a reduction in the blood thinners over a period of 2 months, and stage a double lung transplant or a single lung transplant later. You could probably also target some of the vessels during the double lung transplant. So we routinely perform grafts to the LAD on a beating heart in patients who have undergone a double lung transplant towards the end of the operation. You could graft the right coronary artery. The target that you generally cannot access is usually the circumflex or the obtuse marginals, because you cannot lift the heart in a clamshell incision. All our double lung transplants are a transverse incision. It's a clamshell incision, does not allow us access to the back of the lung. So trying aggressive techniques like bypassing vessels like the posterior descending artery, the PLB, or obtuse marginals is generally something which is fraught with danger, and we do not even indulge that, because that's against any surgical, whatever level of surgical dexterity you have. We sincerely cannot attempt to do that operation because it would lead to failure. Patients who have significantly reduced ejection fraction, they could be significantly risky to conduct double lung transplant in them. But we've also noticed that some of these patients who, like Urmil said, on an MRI, do not show any evidence of scar or permanent disfigurement of the ventricle, would be considered for a double lung simply because they have myocardium which is unfortunately hibernating because of hypoxia, not just because of coronary artery lesions, patients with severe esophageal dysmotility. It's very difficult to treat them with a double lung initially because post-operatively when you start feeding them, unfortunately, the degree of reflux can trigger an early chronic lung allograft dysfunction. It could also be a contributor for acute cellular rejection. So we are very careful with patients who undergo double lung transplant when they have significant hiatus hernia or significant GERD. Patients who have are obese, BMI is about 35, patients who are cachectic or are frail with BMIs less than 16, patients with bad bones, osteopenia, because we know for sure that steroid therapy and immunosuppression after lung transplant could significantly impair their health. Any medically induced fracture after a lung transplant could be lethal for many of these patients. Many of them have osteoporotic spines, they have bad hips, they have very poor skeletal muscles along with poor bone structure. And these are patients who unfortunately sometimes can have catastrophic injuries after a transplant, which could limit their life. It could also limit the degree of rehabilitation. The lung is disconnected from the brain after lung transplant. So there's no sympathetic or parasympathetic mechanism to drive the lung to function well after lung transplant. It has to be the physical effort and the repeated training of patients to be able to breathe well, except in the night when we induce deep breathing by asking them to use a BiPAP. We forcibly keep a BiPAP machine on so that we can expand the lungs to the fullest capacity. Serious physical, psychiatric or neurological or psychological or cognitive disorders can significantly impair medical adherence and thereby significantly shorten the longevity of these patients. Any human being with a poor support system, probably a split family, elderly parents, unfortunately no relatives who will probably be able to stay with them as care after a transplant, unfortunately, and cannot be part of the caregiver plan, makes you come into the higher risk category because it's not discharged from the hospital after a successful surgery. We consider a successful operation when we have more than an 84-85% survival at 1 year, and we have more than 60% survival at 5 years. That is probably something that would be a calling card of a good transplant program. We would not be happy with just making sure that the patient walks home. That doesn't mean anything to us. A lack of understanding of the disease from the patient's perspective is also a significant problem for us because there are some diseases that can recur in a transplanted organ. So making sure that patients understand this, their families understand this, is a process that we begin before the transplant. Many infections that Urmil said are unfortunately unmanageable in our setting. In India especially, we are seeing a significant rise in multi-drug resistant gram-negative bugs, and we continue to transplant in the presence of all of this. So while it is not a contraindication, it definitely is a bigger challenge. So you need to have greater care, you need to have more protected facilities, you need to minimize patient contact after surgery, you need to have so many barriers between patients and the crowd or the treating physicians in many ways. So isolation is crucial. Many other things like a prior hepatitis B or C infection with a significant viral load can also be a challenge when you do a transplant. Though we have direct acting drugs right now on both B and C, we truly believe that patients who have hepatitis of any form tolerate these medicines not as well. And there's always a chance that the interaction of direct-acting antivirals and some of the medicines that we give them post-transplant would unfortunately sometimes be catastrophic in many patients, dropping tacrolimus levels precipitously many a times, leading to episodes of rejection. So patients with all of these infections, some of them having significant chest wall, a misshapen chest wall, probably a contracted space in one of the chest cavities, could lead to us making changes to the size of the donor lung, which is not ideal. So anyone with spinal deformities or significant reduction in chest cavities are patients who are probably not the best candidates. I think we've been very fortunate that in many ways our understanding of lung transplantation was accelerated immensely during COVID, because we were faced with a deluge of patients. More than 180 patients went through our services across 5 cities in nearly 18 to 24 months. They were retrieved from all across the country. They were on ECMO from between 40 days to 180 days. Nearly 30 of them got transplanted in various centers except Bombay. Bombay was a little tough because donations had a complete clampdown in Bombay during those times. Otherwise, there were a significant number of patients from Maharashtra who flew down to our other centers to be transplanted while they were on ECMO. We've had an exceptional outcome with that. We're glad to say that 74% of these patients now continue to survive beyond 6 to 8 months. Many of them have completed an year. And that is only simply because of people like Urmil and people like Ketan, teams that are very aggressive, especially in the post-operative setting. While as surgeons, we like to take a great deal of credit for this, I truly believe that surgeons have a very limited window of opportunity as far as the treatment of these patients. Yes, doing a perfect operation is the first fundamental keystone to be able to deliver good care. But the level of intervention and monitoring and close regular follow-up that intensivists and pulmonologists do is remarkable. And that is truly the reason why working with rehab teams, they have such exceptional results in the long term. So I think all the credit to long-term survival should go to medical teams more than anyone else. It's also important to know that anyone who's had a lung transplant and exhibits early chronic allograft dysfunction or something we call RAS, restrictive allograft syndrome after lung transplant, are not good candidates for a retransplant. So many of them sometimes are told that probably a retransplant is not a good idea. So coming to risk factors, and I'll run through them. An older age obviously is more risky. Lower glomerular ejection fraction, mild to moderate coronary artery disease, patients who had prior intervention, reduced ejection fraction, peripheral vascular disease, because that could be aggravated or augmented after surgery simply because we would be using steroids in larger doses. We would also be using many other drugs that could affect the metabolism of cholesterol. Connective tissue disorder, patients with CT-ILD are obviously patients who are slightly more difficult to deal with because they have multi-system disorders. It's not just their lungs that are impacted. Scleroderma patients have a lead pipe esophagus, they have issues with digestion, motility of the gut, and so on and so forth. And why does this impact some of these patients? Because nutritionally, they're not able to match up as well as other patients who undergo lung transplants. And besides, I think their absorptive capacity and the bioavailability of many of these medications are significantly impaired when they have gastrointestinal disorders, which are generally multi-system in nature. Thereby, our focus as when we look at lung transplantation as a team that is involved in lung transplantation, we're always thinking about the gastric system. You will not imagine the heart doesn't worry us that much. We're always worried about the gut. Is the gut all right? Is the gut all right? So we are just asinine about the gut. Many blood-related disorders like thrombocytopenia, leukopenia, and all of these conditions can impact the survival of patients after a transplant. So while our focus is not the operation per se, the operation is like any other standard operation. Yes, it is technically more hazardous. It is technically very challenging. It is more about logistics and timing, trying to keep the organ out of the body for as little as possible. So all efficiencies, right from picking the organ from a donor center to implanting and perfusing the second organ, is everything that the entire team is worried about. Ischemia time's got to be less than 6 hours. Our only goal completely stays focused towards reducing ischemia time, that is out of body organ time, to less than 6 hours, which is a monumental task to achieve. Because the longer time you take, the worse is the quality of the transplanted organ, and the worse is the quality of life. Many other risk factors that I will not go into great detail, that we've already spoken about in brief, are over here. So to sum it up, selection is an evolving discipline, and every new year, as we see new challenges like COVID, we will obviously get better at selecting and deciding patients. The good part that I feel is in a therapy that was non-existent in the country 5 years ago, we've been able to repetitively do large numbers, close to 80 to 85 double lung transplants annually in this country. And that leads to a great deal of data generated within this nation, which tells us what it is to do lung transplants in the third world. Something that we were only following guidelines that the West had set for us is guidelines that we will now set for practicing guidelines in Asia. And that's why a young team like Urmil and Ritin and Ketan would significantly contribute to how the knowledge is generated in this field. The important fact is we need to widen the net for treating patients with end-stage lung disease. We need to let our colleagues in the pulmonology services across the country understand that good outcomes can be achieved in collaboration with them. We maximize safety, we maximize organ justice, and we use the ISHLT guidelines that I spoke about earlier as the standard candle. So that should be the lamp that we should follow. Individual centers can stretch their experience and do some complex work, but unfortunately, most centers, if they do not have that expertise, sticking to guidelines and sticking to standard selection requirements, trying to operate patients who are not significantly oxygen dependent and not cachectic or probably extremely obese, women to be avoided in the initial parts. These are general guidelines that most centers should follow. And finally, I'll come into some very brief surgical considerations. The older patients have greater comorbidities, and thereby they generally have lesser reserve. So they have greater risk. Females, unfortunately, beyond 50 have a slightly higher risk than males simply because their body undergoes many changes during that phase. They also, sadly, do get slightly obese, not just because of their sedentary behavior with the disease, but also because steroids play havoc with women's bodies. They also, unfortunately, end up being diabetic and hypertensive as a consequence of long-term therapy. They also, unfortunately, have a tendency to have the ability to have other illnesses related to lung disease, which could be autoimmune in nature, and thereby they unfortunately seem to have a slightly higher risk. One of the surgical challenges that we have with women who are slightly on the obese side is this being a chest procedure. We have to go through the breast. We have to make sure that the breast has to be secured and safe and not damaged, because that can cause women problems in the postoperative phase. For women recovering from surgery, unfortunately, the size of the breast can significantly increase their discomfort after surgery and also impair wound healing. So that's something that we are generally very, very cognizant about, and we try to ensure, though we cannot reduce weight in these patients before surgery, so we have various techniques surgically to bypass some of these problems. Patients with BMI, especially on the obese side, as I said, is an increased risk factor for graft dysfunction or non-cardiogenic pulmonary edema type ARDS, as Urmil mentioned earlier. So the magnitude of pre-transplant weight loss is directly correlated to improvements in post-transplant survival. Hypoalbuminemia, as does patients who have poor nutrition, who unfortunately don't do too well after transplantation, and they need aggressive therapy after a transplant. The frail you are, it increases your susceptibility to stressors. Surgery itself is a huge stressor. Allosensitized patients. All of us have a fingerprint, a digital fingerprint, like our thumbprint. And everyone is very unique in the way he has his digital fingerprint. Maybe probably close to your identical twin, but it may probably be fairly close to your sibling, maybe partially share it with your parents. But organ transplantation, especially diseased organ transplantation, only happens from a non-related donor of same blood group. So the digital fingerprint is significantly different. And our challenge starts at that point in time. How do we probably try to figure out how to deal with patients who are allosensitized? For example, if I am allosensitized and I have a high level of PRA, I might reject almost any organ that's given to me. So the attempt to try to neutralize or dilute those antibodies starts in the operating room as soon as you receive the report, which is a direct cross-match between donor and recipient. The minute the pulmonologist gets that report from the transplant coordinator, the anesthesiologist and the intensive care team start treating the patient while we do the operation. They'll start plasmapheresis and start diluting with IVIG using the perfusionist on the back end to make sure that there are not significant fluid shifts. And by the time the second organ, hopefully the first, maybe the second organ, by the time it's perfused, we at least neutralize the level of circulating antibodies to prevent rejections in the short and the long term. So while it sounds very lucid when I tell you this, it requires tremendous deal of focus and surveillance for teams that are outside while the surgeon is stitching the organ up, teams that are outside to be able to access information, pick it up and transfer it into scientific understanding and then utilize that. They deploy it. They don't ask me anything. The anesthesiologists, pulmonologists who keep doing this on the back end. At the end of the operation, you know they've done a flex and IVIG and you need to do it 3 or 4 more times. So these are things that teams that are well trained and do this repetitively get extremely good at. There is a significant challenge with lungs, unlike livers and hearts. and so on. That is donor and recipient size match. Most patients with ILD have contracted chest cavities. Females, generally, sometimes when they get male organs, unfortunately, it's difficult for us to fit that organ in. But what do you tell a patient who is O positive, who is on 15 liters of oxygen and barely able to probably walk even 2 paces, who is on a hospital bed, and the only hope is a matching blood matched or hopefully a size matched organ. So many a times after a transplant, because most donor organs do have a certain degree of swelling, simply because of the process of brain death, which causes a catecholamine storm, because of the extensive amount of IV fluids that are utilized, and a general body inflammation. Many of these lungs are unfortunately sometimes fluid laden. Though they are good lungs for a transplant, we wait for these organs to shrink after surgery. So when we wait for these organs to shrink, in 20 to 30% of cases, direct closure of the chest is possible after a successful lung transplant when you wean off ECMO. But in some cases, we would utilize methods where we would hermetically, using antibiotics and vacuum suction drains, we would hermetically seal the chest cavity, do not wire the chest close, wait for 48 hours. When the lung edema settles, we'll go back in 48 hours later and close the chest. And that allows us to sometimes leave that lung completely without any kind of extra anatomical surgical reduction. So when we have to close chest, sometimes if sections of the lung are slightly larger, we use surgical staples that are backed with bovine pericardium, and we trim off segments of the lung so chest closure is easy. Because if you have a large organ, it can compress not just the heart and cause hemodynamic disturbance, but unfortunately certain segments of the lung can just stay compressed and non-inflated, which could lead to long-term effects of that lung and segments just vanishing away, probably torsions of the segmental bronchi, and an operation that will not benefit patients in the long term. So there are many things that we have to look into it. It's difficult sometimes for us to do it preoperatively, but there are many rules of thumb, and experience is a great teacher. So we compare chest X-rays between donor and recipient. We measure based on CT scans, we measure lung volumes, we look at ratios. We're very careful about gender. We try to match female donors to females as much as we can, or males to males. But sometimes we have to be cautious about what we do when we do it, when we make decisions. Finally, the recipient surgeon will use eyeballing to make sure he knows how the recipient is. So Ritin would know what the donor is, and because he's seeing that lung, I'm at a peripheral position to be able to make that decision. So Ritin, Ketan, Urmil, they would be at site and they would say, well, we can take this for this gentleman, or we would not. We would also have a reserve recipient. Many a times, donor agencies do not allow us to have more than 2 reserve recipients. But going forward, as we do more and more transplants, they would be able to understand that these eventualities can happen. That when you go there, simply because the one who assesses the donor and gives the measurement to the donor organization, that is ZTCC, probably is not measured the height correctly. And that can lead to significant impact on selection of a lung recipient. So when we have poor information, we make poor decisions. So eventually we have to change the recipient choice when we are at the donor site, when we're evaluating the organ. Many patients who have lung disease could have had previous chest tube insertions. They could have had lung volume reduction surgeries. They would have had probably, nowadays we don't do open biopsies because pulmonologists get incredibly good at doing everything with VATS or endoscopically or transbronchially. But so in previous times of patients who have been ill for quite some time, some of them have had open lung biopsies. They've probably even had lobectomies in the past. These can be operating challenges. Why? Because there are plenty of adhesions when you enter the lung. And when you do a double lung, if you have many vascular adhesions, sometimes when you go through these adhesions, they can bleed after surgery. Because it's an extensive chest incision. We go from one end of the axilla to the other. We go across the sternum. We divide 2 mammary arteries. We divide every single structure between the lung and the heart. Most patients who have ILD have dense mediastinal nodes. Many of them are fibrotic by nature, densely adherent, heavily vascularized. Patients who have had surgeries in the past have adhesions that are so dense that the lung is almost stuck to the chest wall. And when you try to create a plane between both, you almost unfortunately inadvertently get into the donor lung. Into the donor's native damaged lung. And that can create air leaks when you perform the procedure. So while you're racing against the clock, you have to be very dexterous. You have to be extremely precise. You have to be surgically in the right plane. So these are challenges that we face as lung transplant surgeons, because we are trying to keep that ischemia time as short as possible. When we do a quick operation and we reduce the time that the patient spends on a heart-lung machine or VA ECMO, we have reduced transfusion. And when we have reduced transfusion, we have lesser risk of developing renal or liver dysfunctions. If we are meticulous with surgery, patients do not bleed, thereby require lesser blood transfusion after surgery. The lesser transfusion you require, the less is the chance that you have TRALI or transfusion-related lung injury. So there are so many things. It's not just serendipity or good luck. It is a figurative attempt by every single member in that operating room, the ones before and the ones who come after, to ensure that we do the right thing in the right sequence to be able to have a good outcome. So if you use the multivariate analysis for patients that pose a greater risk, I would say patients who are more than 65 with comorbidities, females more than males, patients who have had previous intrapleural procedures or are allosensitized have a higher risk. We routinely face challenges where patients who have had an aortic valve replacement or a CABG in the past would come to us for a double lung. Now, clamshell is a problem because when you've done a stenotomy for a coronary artery bypass, you're going across the chest like Jesus Christ crucifix. You unfortunately are going to open the mediastinum once again. And when you do that, you have patent mammary arteries, you have grafts, you have to go through the midline, probably the right ventricle is stuck to the chest wall, and you really can't go across. So we end up doing bilateral thoracotomies. We can do the right thoracotomy, we can do the left thoracotomy, and then individually stitch lungs up, which is called the minimally invasive approach, which is feasible, but unfortunately it has some challenges, especially when you have grafts, because on the left side, if you have grafts going to the obtuse marginal or various areas of the heart on the left side, most of these grafts lie on the pulmonary hilum. They're lying over the left atrial appendage and they're lying over the left pulmonary vein confluence or the LPA. And you cannot see that when you're going through the left chest. If you damage these grafts, the patient would die on table. So every double lung transplant, unfortunately, in a patient who's undergone a CABG previously, is fraught with immense danger. And thereby, this is generally a very restricted option for patients who have had coronary artery surgery or valve surgery in the past. We would generally try to be very confident or sure of where the grafts lie. So we would use reconstructive methods, like probably doing a coronary CT, trying to figure out where the grafts lie to make sure that the surgeon has a guideline as to how to operate. We would utilize central or peripheral VA ECMOs. We would be careful with how we take down adhesions. There are other challenges, miscellaneous challenges, just to end the presentation. Short women who are overweight with oversized mammaries, as I mentioned earlier. Significant donor and recipient mismatch. So many patients with ILD would have significantly large trachea and bronchi. So when you bring in a normal donor lung, you will see that there's a almost 3-to-1 mismatch. A small donor airway and a large recipient residual airway. So when you try to fit this in, you have to use methods where we use something in simple terms, invagination of the donor bronchus. So we stitch it differently. And this has long-term repercussions. When we do it, it has to be so precise, because if you have nooks and crevices in the anastomosis, it could lead to secretion stay pooled there. It could lead to distortion of the lung tissue. It could lead to vanishing or dissipating airways in the long term. And also when you do all of this, it's very important for the general audience to know that the trachea is the most avascular structure in the body. When we do a transplant, it has, when you divide a trachea, you divide all its blood supply. And when it heals back in a situation where you're giving him immunosuppression and steroids, the healing is extremely poor. So many patients can have, and your airway is exposed to air. And you can breathe in bacteria which are drug resistant, you can breathe in fungi. And if they are colonizing that airway, you can imagine how difficult it is for that airway to heal. And this is exactly where the challenges with lung transplant come in. This is exactly where the expertise of a team that routinely evaluates the airway, does bronchoscopies, serially checks cultures, making decisions that can have long-standing impact in what would I say, in outcomes. Many a times, therapies that we utilize to bridge patients to a transplant. Patients who are on a ventilator, when they move towards a transplant, they already have varying degrees of ventilator-associated pneumonias. They have myopathies because they have neuromuscular paralysis. They're physically compromised. they've had minimal opportunities for rehabilitation, which can have a significant impact on recovery. Patients who are on ECMO are even worse as compared to those on ventilator. So anytime we have patients who are either ventilated or on ECMO, our goal is to keep them awake, put them on a tracheostomy, run the ECMO as you can, and mobilize them on ECMO. Get them to do aggressive physiotherapy, try to keep making them learn how to breathe so that you know when you do a transplant, which would happen the next day, a week or 2 weeks later, you probably have these patients already undergoing various kinds of training. With infectious diseases, I won't go into great detail, but what I would like to say is that with HIV, if you have a low detectable viral load, yes, some of these patients still can have a double lung transplant if they need one. With patients with HBV and HCV, both of them, we have direct acting antivirals. Connective tissue disorders, as I said, are part and parcel of patients who have ILD. Our major concerns are, is the heart involved by this connective tissue disorder, or maybe a disease like sarcoidosis? Is it going to cause conduction abnormalities? Would we have myocarditis? Does this patient have heart failure? So these are other things that will cross our mind when we make our selection. Patients with systemic sclerosis, it's a multi-system disorder. It affects the entire vasculature of the body. That can have hypersensitivity response to vasopressors after surgery. So we're very careful. We've had patients who had gut ischemia, patients with systemic sclerosis who underwent a double lung transplant. You do a perfect operation, post-transplant, their gut doesn't move. And you come to know because you use small doses of vasopressin, they've got ischemia, and they've, unfortunately, some of them even perforated. So these are challenges that you have to realize. And any organ, secondary organ that's involved in a multi-system disease, which requires lung transplant, you have to be very careful. GERD, I won't go through great detail. Urmil mentioned about that. Hematological, as I told you, our big challenge is when we start immunosuppression, many of these patients drop their counts precipitously. Platelet counts are down, white cell counts are down, and if they have had pre-existing hematological disorders, it can be a serious challenge. Frailty, as I said, you should take these patients up with great degree of caution because many of them have not just physiological but even psychological deficits, and that can not just increase their transplant mortality before, but even after surgery. Lastly, allosensitization, which, as I told you, we have a certain cutoff for many of these patients, but most of our recipients, being women, would definitely be allosensitized because they've had multiple either pregnancies, they've had missed pregnancies or abortions. Unfortunately, some of them, because every time they're exposed to a partner's DNA, and they're also exposed to an in vitro fetus every single time. So when they're, and if they have ever received a blood transfusion, it becomes an even bigger challenge. Lastly, with psychological factors, not too much. Urmil mentioned about that. We look at the CPAT score with nutrition and rehabilitation, as Sir just mentioned a little while ago. These are modifiable risk factors, but they're considered as game changers. And unfortunately, we don't focus on that much, but we truly realize that patients who have poor reserve or have poor motivation and a general acceptance of their health, sad health, they blame fate for it, they really don't do too well. So it's very important for us to try to change their mindset before surgery, but also post-transplant to promote early extubation, mobilization, drain removal, and try to achieve that 6-minute walk test of 200 meters or 250 meters as early after transplant as possible. So while we have many disease-specific considerations when we select patients, lung transplant outcomes can vary significantly between recipients simply because the way we select them and their clinical characteristics, and we have different guidelines to setting risk categories. That's very important. It's very, very crucial that certain centers with a great level of expertise are the only ones who try to transplant patients with higher risks. And whenever possible, all modifiable risk factors should be optimized prior to lung transplant. So we have good, successful surgery, good short, medium, and good long-term outcomes. And as more and more transplant centers provide transplants for complex candidates, there's a lot of data that would be generated, and I think that would further research and would make our individualized case-based recommendations better, and we would end up doing great work. Thank you very much for your time. I'm so sorry that I kind of extended beyond the allocated time. Thank you. Thank you.
Thank you, Dr. Atavar. I'm sure nobody would have minded you going over time. I think everybody was really engrossed into seeing the nuances of the surgical aspects, or at least the considerations of the surgical aspects of lung transplant. I think it's summarized that lung transplantation is no mean feat. It's a very calculated decision that one must have to take, both for the caregiver and the patient and the team caring for it. So on that note, I'd like to thank all the speakers for taking time out and coming here. Can I request Dr. Atul Mashru on behalf of C Ward to felicitate Dr. Atawar and say a few words, please.
So I thank Reliance Hospital for organizing such a beautiful lecture, informative lecture on lung transplant. See, formerly we used to send our patients to Hyderabad. I think the whole Hyderabad has come to Reliance Hospital. So I thank you, all of you. Yes. I think my own patient is getting lung transplant very shortly.
Yes.
I think I think we have done the pre-operative checkup also.
So whilst we wait, start our panel discussion officially. So, so can any burning questions from the audience? Yeah. Can I request you to introduce yourself, and if there's anyone specific who you need to answer that question, please.
So, well, that's a very practical question. So, pre-operatively, and we always say, okay, so the psychologist and psychiatrist to understand the system that is and the independence. And based on those, their recommendations, usually, I mean, the patients are referred to as pre-operatively, they are in a very difficult situation with end-stage lung disease, with high oxygen support. So, we don't have much time of intervention at that point of time, but post-operatively, what we have seen up till now is that once they go through the lung transplant, invariably most of these smoking habits, they usually do not go back. And that's been a very practical and anecdotal experience. And because they see that when they go through a process of lung transplant, which is such a challenge and which has a high risk and so much of complications which can happen, and it's really a tough journey post-operatively. So we haven't seen up till now, and most of the patients, they do realize that smoking somehow affects the lungs. They have a new pair of lungs which has been donated by a family, and they respect the donation. So usually, we have not seen practically any patient going back to a smoking habit post-operative. But in case if there is a red flag alarm signs pre-operatively by the psychologist or the psychiatrist, there is a high chance that there is a risk for post-operative smoking habits to be restarted. Usually do follow-ups make them follow up with the psychologist or the psychiatrist to understand, and then whatever intervention required needs to be done. But practically, as I mentioned, we haven't seen anyone going back to the smoking habits again, because most of the time, I would say 99% of the time when they are referred to us in an end-stage lung disease, they have already stopped the smoking a couple of years back. So usually don't come across this kind of scenario.
And just a safety great answer, but that's a great question because I think the problem in India is pan playing more than smoke. I've also seen some of them who unfortunately desire or yearn for whiskey or alcohol after surgery, and that is a significant challenge for treating physicians because with so many drugs that all go through the liver, as far as the metabolism is concerned, early on certain antibiotics and later on drugs like tacrolimus and Celsec, which is mycophenolate. We are always very worried about how their metabolism, liver metabolism and alcohol can impact. So while we have to make some concessions in patients in the long term, it always worries us a lot. And many of them do not even tell us that they would love to have a glass of whiskey or probably some wine. So we go forward telling them probably a little red wine once in a while is okay, kind of things like that. But yeah, smoking definitely, I would say that since we don't do many COPDs, especially smokers in India, most of them have been ILDs, and many of them probably even if they once they develop ILD, they generally give up smoking altogether. So more of the problem on the pan side than with the smoking.
So I'll have one question. So let me introduce myself. I'm actually radiologist PRC hospital. And first of all, I'd like to congratulate that this is one of the most exciting and interesting, which nobody has got exposed to this kind of field at all. So I also have this chapter of lung transplant imaging. I just brushed it as well because I've never come across in my life. But now this is there, we are doing it. So it's very much interested to go back and see that. First and foremost, like you have so much of battery of tests that you are going to do before you do the transplant. From jerk to sonography to X-ray to MR imaging, CD, so many tests are there. How much time does it take to prepare the patient and just put him onto that? Because he'll be psychologically too much, So and there's so many other tests that I mean, you have to do it, but it's going to take some time. It doesn't happen so easily.
So usually when there is a first point of contact, and the pulmonologist of course they refer to the transplant clinic. The first OPD visit is always spent time educating, giving information to the patient if they have brought the patient along with it. Most of the time the family members come, patient is not brought because the patient is on oxygen support. So usually then we arrange a video call with the patient also, because it is important for the patient also to understand that what is the meaning of a pre-transplant evaluation. So it's going to be a battery of 50-60 tests to be performed over 5 to 6 days time. Then getting all that data compiled, we have a transplant meeting where it's kind of an MDD discussion where we have pulmonologists, surgeons, anesthetists, cardiologists sitting together and figuring out, and then we come to a clean conclusion that, okay, whether the patient is a candidate for transplant or not. So the whole process is part of a first sensitization to a transplant clinic. We always explain to the family and the patient that this is going to be the crucial step, the first step or the basic step, that we are going to do an evaluation. It's going to be almost 50-60 tests comprising of whether it's angiographies or scans, Dopplers. So they are aware about what they are entering into as a first step. And once we have these evaluations done, within I think 2 weeks time, we usually have an MPD discussion when we have compiled data, and we are able to give a team decision. Okay, you're not a candidate, or you are a candidate for a double lung or combined heart lung. And then comes the second step of registration on the waiting list. So that is how the initial process goes. So roughly after the evaluation is done, after the patient is discharged, within I think 2 to 3 weeks time, we are in a position to convey a decision to the family that whether we can go ahead with the transplant or we have to still wait.
If I may just add to that, I think when a patient walks into a clinic for a transplant, the first question is why should we not transplant? Why do we not transplant this guy? Not from the lung standpoint, but why do we transplant him or why do we not transplant him? So if we ask ourselves that question, we first look at does he fit into the criteria at all? For example, somebody is really frail, who's very, very unwell and is old, and we know that this chap is not really going to sustain the procedure. Obviously, before we start investigating whether he has a lurking malignancy in him, we make that decision very quickly. If you understand that the patient does not have the mental reserve or he doesn't have the family support, so the barrier of entry is restricted there. We don't go beyond. But then as we understand patients better, we realize that he probably has a chance and he probably desires or wishes to probably do well. He has, like I said in my second slide, if he has a good chance of doing well in the long term, yes, there's probably a chance that he will take. Unfortunately, in our country, we still have so few patients who turn up for transplantation that we sometimes look at 65 and 70-year-old patients, which is generally now what we see most. They are the people who have the money. They are the people who want to spend on their health. They are the people who want to live a productive life. While in the US, if you look at 65-year-olds, they will allocate them one lung. They'll say, because let us maximize the use of 2 lungs, give it to 2 65-year-olds, rather than give 2 lungs to one individual. But we know for sure that science tells us if we give one individual who requires a lung transplant 2 good working lungs, he definitely has a survival advantage of probably a year or 2 over one who has had a single lung. So in India, we are fortunate in many ways that we are able to give double lungs to most individuals who require a transplant rather than resource allocate organs. That is one. Second is, suppose we have somebody who is critically unwell, let's say a 50-year-old gentleman, and he's turned up for a lung transplant and he's unable to walk even a few paces, like you said. We probably would utilize the PET scan. If you do a whole body PET, you would certainly know for sure if there's anything lurking anywhere. And if you know something of significance, then obviously it is a decision that which would alter our eventual plan. So some of these tests can be, what would I say, streamlined. Some of them can be accelerated, and then within 5 to 6 days, we will have a general impression about what to do. For example, we have a right heart cath, which gives us some ambiguous information. A quick PET scan might, a quick MRI might help. But sadly, like you said, many patients are so oxygen dependent, may not even be able to lifeline. So these choices have to be made. They are difficult choices, but we rely heavily on our colleagues like you to be able to allow us to make that decision. For example, last week when this lady underwent a PET, I believe the entire radiology team, the intensive care team, everyone from the administrative side made sure that a lady who was on 40 liters of oxygen could have had a MRI. I can guarantee you it would not have been possible in any hospital, not even in Hyderabad. We would not be able to do a MRI for a lady on 40 liters of oxygen, I can tell you. But that's where a terrific hospital, a hospital that is almost every implement that is available in the medical armamentarium, and the number of people that it can throw to the problem becomes very important. That's truly why I believe that this center will do exceptionally well in this field.
And the number of patients that you get in your hospital who have come for lung transplantation versus the number that you do, the percentage that they get selected to do the operation. What is the number of rejections that when people come here for lung transplantation? How many of them you do it, and how many of them you feel that they are not fitting in the category? Because selection is a very, very important criteria.
Yes.
The percentage of getting it accepted.
So right now, sir, what we look at is if we know that this patient would do reasonably well after transplant, then the question that crosses our mind is, will you be able to afford it? That's a very important question. And I'll tell you why. Because many of them can afford the operation, but most of them cannot afford the long-term care of after transplant. For example, if you have to spend.
No, I'm not asking about the financial part.
No, I'm telling you, sir, I'll come to that. That also becomes a very major deterrent. For example, somebody who is being allocated 35 lakhs of rupees by a government agency, but it says this is all we will give you and nothing beyond it. So many times patients who want to continue to do well after surgery need to look at other sources for funding, and that limits their testing and that limits their longevity, because many times if they can't afford the drug, they will not be able to do well. So those patients, we are very conscious and we tell them that you may not do very well in the long term. Don't even make this attempt. Try to probably ignore this option. But patients will come back. I think the important part is telling them why we should not transplant you when you have limitations. This is just one example. There are many other examples. So when we tell them that, they really understand the value of this transplant. They understand that it is very important for them to take care of themselves in the longitudinal extent. Some of them who live in Delhi, they say, we'll relocate out of Delhi. It's not an easy decision. It's a change of job, it's a change of family, it's a change of so many things. But for patients who are sick and they understand this therapy well, they're willing to make many of these changes. As a team, I think it's important for us to bring these forward to patients rather than make a paternalistic decision. अरे आपका lungs खराब हो गया, आपको lung transplant लगेगा और हम लोग operation कर देंगे. So I think if we avoid that process and we spend more time talking to families and making them aware of all of this, I truly believe that the program also moves forward and we have greater outcomes and more confidence in the program. So that's what we like to bring, forward. So unless we do these things, and I just gave you money as one example because that is the biggest challenge in our country. Most patients can't afford the operation. Everything else is medicine. We can deal with medicine. We have ways and means of deciding whether somebody can have a transplant or not. उसको कुछ complex infection है, Burkholderia है, pan drug resistant Burkholderia. Urmi will say there is no point in doing this operation. Patient will understand. Active tuberculosis नहीं कर सकते. आप 6 महीने के बाद आओ, treatment करके आओ. Those are clear-cut decisions, but some of these decisions are emotional and they're difficult. So unless we make families aware of that, and there are a pretty good number of them. So unless we make them aware of that, we will not be able to do it.
Okay, thank you. So there's one question online from Dr. Zahir Abbas, and it's to you, Dr. Akhtar. As mentioned by yourself, that post-transplant lungs are not under control of brain and requires NIV support post-surgery. How long does this NIV support? How long is this NIV support required?
That's a great question. I think when patients are awake and they're active, I think there is a certain drive in breathing, and the patient can be reminded to do that. They generally would like to exert and achieve the same. So early rehabilitation includes getting patients sit on the chair as early as 24 to 48 hours after extubation, getting them to walk within the first 72 hours after they're off the ventilator with a successful double lung transplant, and making sure that they go back to the rehab within probably at least a week after their surgery. If we do not put efforts in this, we will never be able to utilize that newly transplanted lung to its maximum efficiency, bring it to its maximum efficiency. Having said that, we need to do all of this in a sequential fashion. We need to start working well beforehand in the past in order to achieve these results in the future. So that is a process that happens within the team. But when these lungs are neurologically disconnected from the brain, obviously there is no central impulse which tells the lung to expand when he's asleep. So thereby we use the bypass for at least between 2 to 3 months after the transplant. Because we do believe that over a period of time, patients do understand and they develop an intrinsic drive of breathing.
which does not get impacted by sleep. But during those first 2 or 3 months, when the lung is accommodating to its new physiology, and also to a denervated lung, as we call it in science, it is important for us to ensure that no single area in the lung is underventilated or has the potential to hold a mucus plug in the airway, which could probably precipitate an infection and cause rejection. So one of the fundamental goals is to keep this lung completely expanded, aerated, make sure that it does adequate mucus clearance, because our pulmonologists will be repeatedly doing bronchs and making sure that by ambulation, exercise, you could probably alleviate the need for a BiPAP for more than 2 or 3 months. You would like to add anything to that? So I think, as mentioned, one more advantage of BiPAP is obviously it helps in recruiting the lung, because I believe that the lung transplant is the only transplant where patient efforts are required post-operatively. It's not a heart or a kidney or liver that is just within the organ and on its own. Yet patient efforts are going to require to do those breathing exercises, to have expand, do incentive spirometries, and do aerobicas, bring out the sputums, keep the airways clean, and recruit the lungs as much as possible to increase the vital capacity. So I think that also becomes an additional advantage if they are using BiPAPs in the night and intermittent in the day. They are not dependent on BiPAPs, but this is just one of the additional importance of using it.
I have one question, if that's okay. Now that we have a whole spectrum which can get transplanted, especially patients with CTD-ILDs. Earlier it just used to be two, azathioprine and mycophenolate. Now we have all these fancy biologics coming in. How do you evaluate a patient who's been on immunosuppression and biologics? Because obviously that's going to affect their cell-mediated immunity as well. So how do you evaluate such a patient, and what do you do with their immunosuppression pre-transplant?
So, I mean, not only the CTDs, those who are on immunosuppressants, we get nowadays chronic HPs also, they have been on azoran or on mycophenolate steroids. So, more or less, the protocol evaluation remains the same. We run through this battery of tests, we continue the immunosuppressants. We look for any active infection foci, so we run through the cultures to make sure that there are no infections, there are no colonizers or no pathogenic infections sitting there, which needs to be treated first before we even think about listing those patients for transplant. So invariably, most of these immunosuppressants are going to be there post-operative. I mean, mycophenolate or azoran with steroid becomes one of the 3 drug immunosuppressions which we use it post-transplant as well. So these are the same immunosuppressants which they are using it preoperatively. So predominantly it is from the infection point of view, as far as the Indian settings are concerned, we are very aggressive on ruling out that they do not have any infection, even though it may be may not be in an active stage, but it shouldn't happen that post-transplant you have a flare-up of infection. So I think from that angle, it is very important to evaluate. But as far as the immunosuppressants are concerned, preoperatively, we do continue that. Specifically, we have come across some patients who are on antifibrotics, nintedanib, they are on azoran, and by the time we evaluate, they have delayed therapies. So when we encounter some subgroup of patients, those who have delayed therapies, we have to then accordingly modify the immunosuppressants, maybe stop the antifibrotics to make sure the liver improves. But we have seen a couple of patients on that aspect, but otherwise we do continue immunosuppressants till the end.
Sure. And I've got one question for Ritan, and that's okay. Yeah. So you mentioned about a 46-year-old doctor with scleroderma. Let's hope for the best and she gets a lung. How difficult is it for closure of lungs in such a condition, especially given that the skin quality is going to be hampered, is going to be suboptimal?
Well, yes, you're exactly right. The disease itself, the healing rates are going to be so we have very less threshold post-operatively to open the wound up, put in a bad dressing and things like that. Yes, the wound healing is bad in these connective tissue disorders. But in terms of sizing the lung, are you asking whether how big it is?
Purely wound healing and closure.
Yeah, definitely. So we will close it in the standard way. So our method of closing, especially with the sternum, we use bands and we're just not using wires. So we haven't seen much of sternal problems either in our patients. But yes, they would definitely be more predisposed to more infections. And yeah, so their healing will be poorer. But I think we'll be able to manage it with the techniques and being a little bit more careful with our dressings.
Okay. So it's not a great concern having.
It is a concern, but there are other concerns as well. There's a piece of visualization. I think those are major concerns compared to this one. What do you say?
Yeah, I totally agree. So what Ritin would normally do is post chest tube placements after lung transplant, there will be additional tubes in the subcutaneous tissue. In the subcutaneous vein, which we call a Romovac dressing. That's a vacuum assisted dressing, and it makes sure that every single drop of serum in the subcutaneous tissue plane is pulled out. More relevant in women, as you mentioned rightly, because when we go through breast tissue in many cases, while we go through a fifth interspace incision, it's very important that the breast does not heal too well when gone through. There's a very poor healing process in a background of immune suppression and steroid therapy. So the best way we can avoid infection is to make sure that there's no residual collection, which allows the seeding of any bacteria. So that is constantly surveilled in the postoperative phase by routine ultrasounds of the chest cavity and the chest wall to make sure there's no residual collection. Any collection will be targeted very aggressively. We, Urmil and Ketan would serially do not just echoes, but in some cases even CT scans to differentiate between a possible collapse consolidation, probably a residual collection in the chest cavity, and probably a chest wall collection. So the problem with transplants is if you leave any focus in the chest cavity that can get colonized, you're creating a lot of problem in the future because your antibiotic therapy will change, your patient's recovery will change, the chances of him getting back into the hospital with complications is going to be very high. So this is there are 4 or 5 people that are just so anal about it. That's the right word. It's just anal about complications. We are only looking at kya complication and kya complication. We are not saying sab kuch theek hai. We are saying ye complication. Every X-ray is scrutinized by 5 people, saying ye aisa ho sakta hai, aisa ho sakta hai, ye karo, wo karo. I think the more you doubt yourself, the more you question yourself, the better you would be. So our focus in a lung transplant program is only this. We keep double guessing each other, saying, you think this, I think this, and so let's clear this. Yes, it is also very important because in the setting, we should not over-investigate patients. So generally, because the team has such incredibly large experience, so these are scenarios we have faced in the past. It's very easy for us to come to a very logical, stepwise algorithm of eliminating problems. That comes with experience. Repeatedly doing the same thing gets you closer to perfection. So as we have younger blood, as we have people who join the team who contribute to this expertise, I think we learn as slightly senior people, we learn a lot too. So I think their energy and their youth brings a lot of kind of vitality to the program.
Okay, in the interest of time, I think we can take probably one more question if there's any. Yeah, we got one.
I have one only simple question. I'm Dr. Vishmakar. I heard in one of the talk that the nervous system, sympathetic and parasympathetic, are cut off from lungs. Do they regenerate by any means, or can we prevent it?
So I believe in hearts we have a similar problem, sir. But in hearts, fortunately, I think there are some residual tissues in the heart that stay left behind, back wall of the LA. There is some degree of parasympathetic and sympathetic regeneration as far as the heart is concerned. Though I believe, based on figures, it's not more than 30 or 40%. With lungs, it may be slightly more difficult. We truly believe that the level of division and dissection is quite extensive because we almost devascularize the entire hilum when we implant the lung. And when we go back, it's just 3 tissues, 3 structures stitched to each other. We are not really very sure how much of this returns, but what is very important is when we started, and this is very crucial. Why lung transplantation was so far behind hearts was simply because when they did early experiments in dogs, there's something we call a Herring-Brewer reflex. So a denervated dog lung would never, the dog would just lose the drive to breathe. So when they did this experiment in dogs, when they did canine lung transplants, none of these dogs breathed after a lung transplant. So while the lung was working beautifully, the dog wouldn't breathe. So the direct conclusion was, if you do a lung transplant, the patient would not breathe. So they did not do lung transplants for quite some time. It's only later on that with time when we realized that there was no relation to this, and humans do not have this bad reflex, though we do have a Herring-Brewer reflex, but not as bad as we have it with canines. So then that's when lung transplantation started. So there are many things that we have learned in the passage of time, but like you truly said, in our experience and what data tells us, it really doesn't matter whether the parasympathetic, sympathetic connections come back. In the earlier phase, our attempt to directly intervene into the airway and make sure that we have good clearance is probably one of the advantages we have over the heart. With the heart, you can't really do many things such as interventional therapeutics. But with the lung, yes, at least you can go into the airway, make sure that things are all right. You can repeatedly assess with the blood passages that the pulmonary artery and the atrium generally do not have much problem. Once you know that they are fine, they are fixed well, there are no gradients intraoperatively, nothing normally happens in the post-op. But the airway is our only focus. We keep focusing on the airway, and we're fortunate that we have great instrumentation to be able to get into the nooks and crannies of the donor and recipient airway, and we're able to clean up a lot of secretions and make sure that new lungs continue to do that. Sorry for that very long drawn answer.
Any innate mechanism to function the lungs in a normal way?
It just works on reflex. I think it just works on reflex, and maybe the brain works on the diaphragm. So the diaphragm actually drives breathing. The brain works on the diaphragm. So basically, and yes, probably Urmil might be able to, or Nimish might be able to tell us more. Maybe the level of PCO2 in the recipient's blood might be triggering some kind of sensory impulse which drives the diaphragm faster. It makes you breathe better. So our focus is not to worry about that. We just focus on making sure that the recipient understands 2 new lungs have to be taken well care of. Probably that's the right.
एक सिंपल सा क्वेश्चन अगर पूछा जाए, and like to just convey this to the public, any program which has to be successful, it requires how to reduce the paperwork, the legalities, and how will you bring down the cost of this transplant? The program cannot survive, it cannot move further unless we have these 2 aspects in our list. It's simple the question. Why would a person then again go? How do you address this and how do you take this as a forward? The paperwork, I mean, obviously there has to be some legal paperwork and all that is there. Is there a big challenge to handle the paperwork and the financial aspect? How do you bring this program?
I'll go and then boys can contribute. So I think that's a very, very important question, and this is one of the questions that I love the most. When we look at paperwork, I think importantly, it's very vital in the interest of patients, especially patients who undergo transplant, to have an electronic medical record. So if you have an electronic medical record or the electronic health record, I think it works beautifully for patients. So in our program, we have an electronic health record, and we have an app that goes with every patient's phone. And this has happened very recently in the COVID era. We came up with this and we are implementing it now retrospectively. So almost all our patients will start getting these apps. The time that will take in patients who have already been transplanted is to pick up all the data from the central server and put it into the app and integrate it, because many times this is the long run process. We are trying to eliminate paper completely, so that takes care of the documentation part. The good part is any patient who has had a lung transplant, if he goes back to, let's say, Bokaro or Roorkela or some place as remote as that, because it's probably a name that not many of you have heard, he could probably go to the local diagnostic center, get his blood test done, and if it is a Lal lab or it is an SRL or any such standard lab, they have a centralized system. They could send us an email. We could probably integrate their services directly into our app, and the information will be loaded just based on the patient ID. So that is something that technology has helped us with. Likewise, it can be done for a CT scan. They could just upload the CT scan, or they could upload the film onto the server. And every time that Urmil sees this patient on follow-up, he has residual data from his pre-operative scan, his trend of renal function, creatinine, tacrolimus, so on and so forth. So I think that is how we are trying to eliminate paperwork and use technology to be able to surveil patients better. As far as the cost is concerned, undoubtedly, very important question. 70 to 80% of the costs are currently, unfortunately, drugs like biologics, which are unfortunately not meeting the country they're imported. The solution that we use for lung transplantation to preserve the lung as it is explanted, perfused, and then brought back to the recipient center costs between 4 to 5 lakhs of rupees. It's 8 liters of solution. It is made in Sweden, and there is nobody else in the world that manufactures this solution because it is proprietary and it is under patent. So while in our country we do not have a solution as such, which I truly believe can be done at 1/10 the cost, we are paying 10 times more because we do not have that drug manufacturing formulary, we do not have that solution in our country, and we're not allowed to make it. So hopefully with time, maybe somebody would come up with this thing, because as more and more transplants happen, the need for these solutions will go up. So as the number of donations go up, as the number of transplants happen, I think there will be somebody in this country who will start manufacturing these solutions. I think that will bring costs down. There are many companies in the field of biotechnology that are now looking at locally manufactured monoclonal antibodies. So hopefully that we will now start having drugs like basiliximab, which is an inducing agent that we use for immune suppression. It probably an ml of solution costs us between 85,000 to a lakh of rupees, just an ml. We have to use 2 doses. Antifungal medications, IV, and some patients after transplant will probably require an IV antifungal or a drug that works against a specific kind of bacteria, which is multi-drug resistant, is expensive. The costs lie there. The costs lie in all of these things that are proprietary, that are under patent, that are imported, and many a times staples. For example, when you do a double lung transplant, we use between 12 to 14 rows of staples. These staples are preloaded because if you continuously start stitching, it will take another 4 hours for the operation. So when we use staples, we can divide, cut, join, we can do everything using staples. That helps infinitely in a faster operation, better outcome. So when you can do that, you are obviously giving the patient the full benefit of a complex operation by using technology. So everything that we utilize towards having a successful transplant, unfortunately, costs us money. Having said that, universally, if you look at lung transplants, when we look at the number of organs that are picked up from donor hospitals, the ratio is between 20 to 30%. So if a retrieval team goes for 10 organ retrievals, they will pick up lungs maybe 3 or 4 times, because that is the only way you will get a good organ. So many times the recipient would come to the hospital, get admitted, get his COVID test, all his blood tests done the previous night. Next day morning, when Ritin and Dr. will go to the donor hospital and pick up the organ, which happened yesterday. We were supposed to do a double lung yesterday. And in one of the hospitals locally, we had a donor. The team went there at 4 in the morning. The retrieval was at 9 o'clock. They spent 5 hours assessing and optimizing the donor. And at the end, when they opened the chest, they found out that the left lung was confused. And it had a non-resolving consolidation in a small segment of the left lung. And because they felt that it was infection, though the donor was on a ventilator only for 3 days, they refused the lung. It was otherwise an excellent lung, but they refused it. So when you go 10 times, you probably get 3, maybe 4 lungs. So every time a team travels internally, locally, not too much of an issue. But when they travel outside the city, when they take flights to another state, when they spend so much of money trying to go and assess a lung, those costs will not come directly to that patient, because we may go 5 times for somebody, we may go 10 times for somebody, and we come back empty-handed 9 times. There are lots of costs that are accrued by the treating hospital, but they do not get transferred to the patient, but they get distributed across 100 patients, for example, because maybe 30, 40 patients, the first attempt will be a good attempt. So sometimes these economics are only taken care by hospitals which have philanthropy or the desire to do good work at the heart of what they are. So if you have hospitals like that, I think we can do great work. And sadly, there are very few centers in our country who believe that they want to do cutting edge technology at cost, where they do realize that there is only a reputational enhancement, there is no financial benefit of doing this. And likewise, it is for physicians who want to work in this science. We obviously have to tell themselves that we are doing it for the thrill of it. We are doing it, it's like Roald Amundsen going to the North Pole. This is in our country, this therapy is such that it is exploration, it is a voyage of discovery and journey. So for all of us, being part of that journey, as you get more and more followers, many colleagues who believe in this therapy, as we grow this and it becomes a safe journey, I think many patients will benefit, many of the teams will pick up knowledge from what we do, and I think we can have a nationwide program which can do great work in this field, like livers and like kidneys, which have become so commonplace. Yes, hearts, of course. Almost every single city has 2-3 centers which do heart transplants. So we hope we see the day when we have many more lung transplant centers in our country.
One last question from Ritin.
So I asked this question. So it's a surgical thing. So over the years that you have been doing on transplant, how was your procedure? How has the technique evolved, especially in terms of the support that you're using during surgery? You have started using conventional artificial bypass. when I had a conversation with you when you told me that you started doing off-form and now you are doing central ECMO. So how was your experience in these years and how you have evolved your technique?
That's an awesome question, but I guess there are very few in the audience, except you probably not many would understand. I try to simplify. So when we started lung transplantation, obviously I had some exposure during my training. I had a couple of colleagues who had worked in different centers that had done lung transplants worldwide. Some of them were centers that continue to be the main engines of lung transplantation in the world. One of them is in Austria, at a center in Vienna, and the other being in Toronto, which is the Toronto Lung Center. Both these hospitals do roughly between 150 to 200 lung transplants annually, and they do cutting edge work, and they've been doing this for more than 30 years. So a lot of our understanding and training comes from there. Another team that helped us immensely was a lung transplant team out of UT Southwestern in Dallas. They have 3 pulmonologists and 2 surgeons helped us immensely in the first few years of our program. They were our mentors, they were our guides, and they made sure that every single patient, that we discussed and decided for a lung transplant was vetted by them on a Zoom call. In those days, we did not have Zoom. Before the pandemic, we used to have Skype. So we used to do Skype calls on Friday mornings or on Saturday mornings for us. It was late evenings for them. What they taught us went along in what we do now. In America, the standard therapy is to try to do many of these patients on cardiopulmonary bypass. That is the regular way that we do heart surgery. Now, the problem with using cardiopulmonary bypass is this, that every single drop of blood that comes into the cavity has to be taken back into the heart lung machine, which has a filter, which collects all of this blood, filters it, and then gives it back to the patient. In patients who require lung transplant, unfortunately, many lung transplant patients have existing infection in their damaged lungs. They have infection in their airways, and then sometimes infection in the donor lung. When you do these operations on cardiopulmonary bypass, you take all those secretions, inadvertent, unfortunate secretions that seep into the blood, they all go to the heart-lung machine and they go back to the patient. This is very sensitive, this is very dangerous, and it is very life-threatening. So we decided to abandon that strategy altogether, and we thought it would probably be better to do an operation without using the heart-lung machine, which is done roughly 30 to 40% times even in the West. All single lung transplants are done without the heart-lung machine. It's called a beating heart lung transplant. So we would do a lung transplant to the right side, wait for half an hour, make sure everything was well, and then we do the left. So while we did double lung transplants off-pump, it would unfortunately take, though it was much safer, it would unfortunately take a significantly long period of time. And that in our simple understanding was not a great technique. So an operation which we could do in 6 or 7 hours, we would probably take 8 hours or 8.5 hours. So we decided that it was important for us to look at a more effective, efficient way of doing transplants without compromising safety. At the same time, trying to keep the organ out time as little as possible. And that's when we chanced upon using the VA ECMO. So we use an ECMO now routinely. The only thing, the barrier for us was ECMO is more expensive. Cardiopulmonary bypass is cheaper. It's infinitely less expensive. But when we do ECMO, yes, we incur a greater cost, but we offset that cost by faster recovery, by lesser risk, and with lesser use of antibiotics and lesser threat of life to the patient himself. So VA ECMO became a standard technique for us. The good part with VA ECMO is we have realized over the last 2.5 years that the routine use of VA ECMO, never ever do a lung transplant off pump anymore. Everything is VA ECMO. That has put a strategy or protocol in every single attending in the theater and the anesthetist and anesthesiologist and everyone else, that all operations are VA ECMO. So the entire process is the same. We do not have to tell everyone It's very simple. VA ECMO, lung transplant, VA ECMO. And VA ECMO goes through here. It doesn't go through the groin, doesn't go through anywhere. So everything is VA ECMO, so everyone is ready accordingly. So there's less exchange of information, less requirement for us to talk about anything else other than the main procedure. Lung coming now, lung coming here, this is the time we implant, this is the time we go out, what blood, what sensitization, things like that. So communication goes down. Lastly, with VA ECMO, we have seen a significant reduction in post-transplant graft dysfunction. What Urmil
used eloquently, used the line non-cardiogenic pulmonary edema, which is ARDS basically. So when you look at that in a transplanted lung, which happens in 30 to 40% of lungs transplanted worldwide, they have a primary graft dysfunction, PGD. There are 3 different grades, 1, 2, and 3. 3 is the worst. PGD is considered as a form of rejection. It has significant impact as far as medium and long-term recovery of patients and longevity after a transplant. So our first goal was no PGD. So when we aim at no PGD, the best thing is the lung is so sensitive, we try to give it as much rest as possible. So when we do this operation on VECMO, the lung is completely rested. There is no stress on the lung, even for a second. There is no pressure on the lung to perform. There is no requirement for it to provide oxygen and remove carbon dioxide. It is just resting. So it's like you've gone on a vacation for 5 to 6 hours after a transplant. So we do both the lungs, we rest the lung, then we take an hour and a half, because after that we have all the time in the world. The only idea is to keep this implanting time to 6 hours, maximum 7 hours. So once the implant is done, then we can take another peaceful 2-3 hours, because the ECMO is a very safe modality. It causes the least amount of cell damage. It is very, very compatible with human circulation. It has no after effects. And as we take time to allow the lung to be gradually loaded, gradually given the work that it is supposed to do, we see that the lungs heal better. Recovery is faster. So after we've adapted this technique, our primary graft dysfunction rates have gone down to almost 0, where almost 99% of our patients come out of the ICU without the need for an ECMO. And that is a true revolutionary forward advance that we've seen in our experience in the last 2-3 years. And that has obviously increased the confidence that patients have in the therapy, that has improved the outcomes, and that has obviously allowed us to advance this science for long answer.
Okay, thank you everyone. I think we were overshot by a few minutes, but I'm sure nobody would mind. I thank the audience, thank the online audience, and of course, all our esteemed speakers for this wonderful CNA. Thank you again.